how, why, where, stay, the placement, the internships, and the future prospects. I would like to emphasize here that our placement is growing day by day. Bangalore being the hub of Silicon Valley, the IT, the development, startups, and so on and so forth. We have our engineering and technology and design campus in the heart of the focal point of Bangalore, which is the PINIA. PINIA houses nearly 2,500 industries, wherein we try to impart training, shop floor and online for all the students on those startup concepts. We have the Technology Business Incubator as well as the Ramaiah University of Innovation Center. Friends, most of you must have been attending our Arohan is welcoming you so that ensure you that when you are on Ramaiah University campus, you will be at home away from home. The cultural programs, the various clubs are going to welcome you. I look forward personally in interacting with you and welcoming you to Ramaiah University of Applied Sciences for making your career great. Please refer to the website ramaiah.university for more details. It will speak about the programs, the duration, and all that you aspire to know from us. Thank you very much. Stay safe, stay blessed.
This sums up the life of Dr. Mathikere Ramaiah Jairam, a name synonymous with education, health and philanthropy. Giving has always been a part of life for Dr. Jairam. Responsibility came early to him, being the eldest of 10 siblings. After his education, his father took him under his wing and founded the Ramaiah Medical College and the Ramaiah Engineering College. Dr. Jairam carried the legacy of growth forward after his father passed on. Today, the institutions his father built are legendary and over the years have gained national and global recognition. Stalwarts have graced the corridors of these elite institutions. Education is empowerment, he believed. He expanded horizons and set up the Ramaiah University of Applied Sciences and School of Social Sciences and Law. Joint collaborations with other universities strengthened his idea of sharing knowledge. He was awarded a doctorate in business administration by the Coventry University, UK. Dr. Jairam's dream of education for everyone, passing umbrella of learning.
All your thinking should be the holistic approach. After all, the whole nature is of inclusiveness. So you have to have inclusive thought process wherein when you come out with your holistic approach, it will be accepted to everybody and everybody will get that benefit.
The Ramaiah Medical College Hospital and the Ramaiah Memorial Hospital provide all healthcare facilities and have been in the forefront of handling health crises from time to time. As an industrialist, Dr. Jairam is the chairman of the Valdel Group of companies with business interests in the oil and gas and manufacturing sectors. Former Prime Minister of UK, John Major, visited Valdel and expressed his appreciation. Kaiwara is Jairam's answer to his inner search. As the Dharmadhikari of the Yogi Narayana Mutt, he has touched the hearts of the people by propagating spiritual values and social harmony. Dr. Jairam's strength comes from his family. Relaxing with them after a day's hard work in the peace of his home helps him take on the challenges in life. He is confident the Ramaya heritage will be carried on for generations to come. Dr. M.R. Jairam is a contented man. He is full of gratitude for what life has handed to him.
Till the life is there, you have to go on working. Whether you succeed or not, that is not the issue today. Our work has to go on till the end.
For him, life holds many more opportunities and looks forward to conquering more challenges.
I have work to do, I have work to do, I have work to do before I sleep.
MS Ramaya University of Applied Sciences is a name to reckon with. Our very beloved aspiring students who wish to make their career at MS Ramaya University of Applied Sciences have a great message for you friends. Myself, Kuldeep Raina, the Vice Chancellor of this premier institution of higher learning. We are in Bangalore and have been in this area of higher education for the last nearly 6 decades. We have diversified from engineering and technology to medical, life sciences, engineering and technology, the design, and several other programs. I am very happy to share with you that Ramaya University of Applied Sciences offers whole sort of programs which are interdisciplinary in nature. We have over the years created beautiful minds who are our very proud alums, and they have become brand ambassadors for the group. In this university, we every time focus on nurturing the students to the best practices of teaching and learning processes. We follow the process of continuous evaluation and also the assessments, the internships, as well as visit to various corporates depending upon the domain specialization. We have a fully flexible, choice-based graded system of education, which integrates with the concept of the new education policy.
न चौरहार्यम न च राजहार्यम न बात्रभाज्यम न च भारकारी व्यये कृते वर्धते एव नित्यम विद्याधनम सर्वधन प्रधानम.
Knowledge cannot be stolen, it cannot be taken away, nor can it be divided. It does not become a burden. Instead, it grows manifold when shared, making it the greatest of all forms of wealth. A very good morning to all the distinguished dignitaries, faculty members, and delegates present here, and those of you who have joined us online. We are your hosts for today. I am Dr. Hajira.
And I am Dr. Nitya. Together, it gives us immense pleasure to warmly and cordially welcome you all to the National Oral Cancer Conference 2025, a national level conference convened on the theme Current Trends in Oral Cancer, Investigation, Diagnosis and Management, hosted by the Department of Oral and Maxillofacial Pathology, Oral Microbiology and the Oral Cancer Research Center, Faculty of Dental Sciences, Ramaya University of Applied Sciences.
Every hour, 5 people die from oral cancer in India, a preventable disease claiming 75,000 lives annually, with projections showing the burden will double by 2040. Globally, nearly 390,000 new cases and 188,000 deaths are reported yearly. Yet, 80% of these cancers are directly linked to tobacco and smokeless tobacco products we can eliminate. The cruel paradox is most cases are diagnosed at advanced stages with just 27% 5-year survival rate and compared to the 82% for early detection. Together, today we gather to break this silence, empower our communities through awareness, screening and prevention. Together, we can transform survival outcomes and ensure no patient faces this disease unprepared.
NOCC 2025 serves as a vital platform to bring together clinicians, researchers, academicians, and students to deliberate on current trends, share evidence-based practices, and collectively work towards improving prevention, early diagnosis, and patient outcomes. This conference stands as a commitment to advancing oral cancer care through knowledge, innovation, and collaboration.
With this brief introduction of our National Oral Cancer Conference 2025, may we please request our beloved Dean Dr. Kavita Prasad Ma'am, Organizing Chairperson, NOCC 2025, to kindly escort our Chief Guest, Honorable Vice Chancellor, Professor Kuldeep Kumar Raina Sir, and our Guest of Honor, Mr. S. Ashok Rao Sir, Registrar, Ramaya University of Applied Sciences, to the dais. Ma'am. We also request Dr. Soumya S.V., Organizing Secretary, and Dr. Dominique Augustine, Scientific Chairperson, NOCC 2025, to escort our esteemed speakers to the dais. We extend a warm welcome to Dr. Srinivas K., Consultant, Department of Dental Medicine, Manipal Hospitals, Bangalore; Dr. Nadeemul Huda, Department of Oral Oncology, Kidwai Memorial Institute of Oncology, Bangalore; Dr. Radhika M. Bavle, Head, Department of Oral and Maxillofacial Pathology, Krishna Devaraya College of Dental Sciences, Bangalore.
We now kindly request all to please rise for the Ramaya anthem.
श्री गणनाथुनी शारदा सत्कबुलनु सहज योगी मुनुलन सुरुलन देव ब्राह्मण धन्युनी सकलांतर्यामी हरिणी चाल भजिन्तुम् ज्ञानं विज्ञानं च भक्तिसहितम् ज्ञान विज्ञान विद्या विनय भूषण
रामय्य समूह संस्थाना
ज्ञान विज्ञान विद्या विनय भूषण रामय्य समूह संस्थान तारे निहार के आगले ಈ ಮಾಲಿಕೆ ಜಯವೆನ್ನುವ ಈ ಸಂಸ್ಥಾನಕ್ಕೆ ದ್ರಷ್ಟಾರರು ಕಟ್ಟಿದ ಕನಸಿನ ಸಾಮ್ರಾಜ್ಯವಿದು
ದೀಪದೊಳು ಪ್ರದೀಪಗಳ ಬೆಳಗುವ ಶ್ರದ್ಧಾ ಸ್ಥಾನವಿದು
ಅರಿವಿನ ದಿಗಂತದಾಚೆಗೆ ಜಿಗಿಯುವ ಸಂಪನ್ಮೂಲವಿದು ಗೃಹ ಗೃಹದಲ್ಲಿ ಗೃಹ ನಿರ್ಮಾಣಕ್ಕೆ ತಂತ್ರಜ್ಞಾನದ ಸೋಪಾನವಿದು ಮಿತಿಯಿಲ್ಲದ ಅಮಿತ ಜ್ಞಾನಕ್ಕೆ ಸಾಧನ ಕ್ಷೇತ್ರವಿದು ಪ್ರತಿಭೆಯ ಸಾಧನೆ ಮಾಡಲು ಸ್ಫೂರ್ತಿಯ ಕೇಂದ್ರವಿದು ಅಜ್ಞಾನದ ಕತ್ತಲೆ ನೀಗುವ ಸುಜ್ಞಾನದ ಸೂರ್ಯನ ರಶ್ಮಿದು
ಜಗದೋದ್ಧಾರದ ಹೊಂಗನಸನು ಹೊತ್ತಿದ ಅರಿವಿನ ತಾಣವಿದು
ಅರಿವಿನ ಹಣತೆಯು ಬೆಳಕನ್ನು ಚೆಲ್ಲಿದೆ ಅಸಂಖ್ಯಾತ ಕಿರಣಗಳು ಎಲ್ಲೆಡೆ ಹೊರಹೊಮ್ಮಿವೆ ಜಯವೆನ್ನುವ ಈ ಸಂಸ್ಥಾನಕ್ಕೆ शीतला सस्यश्यामला मातरम् वन्दे मातरम् शुभ्रज्योत्स्ना पुलकितयामिनी पुल्लकुसुमित द्रुमदलशोभिनी सुहासिनी सुमधुरभाषिणी सुखदां वरदां मातरम् वन्दे मातरम् वन्दे मातरम्
Thank you. Kindly be seated. Saraswati Namastubhyam Varade Kamarupini Vidyarambam Karishyami Siddhir Bhavatu Me Sada. By invoking the blessings of Goddess Saraswati, we now proceed with the inaugural ceremony.
The ceremonial lighting of the lamp signifies the illumination of intellect and the pursuit of knowledge. This flame marks the beginning of a journey towards innovation, service, and growth. We now invite our dignitaries for the traditional light lamping ceremony.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you to all the dignitaries. We now move on to a very special moment, the release of the Constitution book. It reinforces our collective commitment to the principles of secularism, liberty, equality, and fraternity. Through this release, we recommit ourselves to upholding these sacred values and ensuring that justice, equality, and integrity continue to inspire and strengthen our nation for generations to come.
To release this book, it is my privilege to invite the chief guest, Honorable Vice Chancellor Professor Kuldeep Kumar Raina sir, to do the honors. Sir, please.
Thank you, all the dignitaries. We now request our respected Dean and Organizing Chairperson, NOCC 2025, Dr. Kavita Prasad Ma'am, to kindly grace the podium and deliver the welcome note.
A very good morning and a warm welcome to one and all gathered here. It gives me immense pleasure on behalf of the Faculty of Dental Sciences, Ramaiah University of Applied Sciences, to welcome each one of you to this National Oral Conference 2025. Very happy and overwhelmed by the response. I think, sir, we have crossed the 450, the registrations. We are very happy to welcome you all. And also, true to the vision of our university and our faculty, what it represents, that is integration, teamwork, interdisciplinary work, and collaborative work. This conference has brought together the specialists from oral medicine, oral surgery, and oral pathology all in one platform, along with all the undergraduate students, postgraduate students, as well as the concerned faculty to have interactive sessions. And this is going to definitely take our understanding forward, and also we can work together to bring better clinical outcomes for our patients. So I'm extremely happy to be hosting this conference at the Faculty of Dental Sciences. And I thank each one of you for having registered for the conference and being part of this conference and to be present here. And sir, on the 15th of December, I think we had about 100 plus e-poster online sessions, which they have already judged. And I think this afternoon, again, we are going to have another 100 plus e-poster sessions. And this is going to be offline. And I'm very happy that the students have overwhelmingly responded to our invite, and they have come forward to participate in this conference. I think the involvement of students is very, very important, because as dental professionals, we are the first to be doing a dental examination, and therefore we have access to do a complete oral examination of the patients, and we will be the first ones to pick up any signs of either a pre-malignant lesion or be it the first evidence of oral cancer. So, and also it is, we play a great role in actually counseling the patients, advising the patients, and we can pick up like if they have any deleterious habits, and we can go ahead with tobacco cessation. And because prevention is what is the most important thing in, especially like, that is what is going to help us in controlling this or this disease, because once a patient gets oral cancer, then we know, all of us know, like in spite of all our efforts, the 5-year survival rates have been low. But such kind of conferences where it brings specialities together, it can help us in better understanding and also probably to improve clinical outcomes. It is with great pleasure and privilege that I welcome our Honorable Vice Chancellor, Dr. Kuldeep Kumar Raina, sir, to this conference. Sir's enthusiasm, his positive outlook and strategy. The Department of Oral and Maxillofacial Surgery and oral and maxillofacial surgeons and the role which they can play and contribute in the management of oral cancer, because still we have to work together with surgical oncologists, plastic surgeons and reconstructive surgeons in order to achieve our goals, together with the specialities of radiotherapy and chemotherapy. And sir is doing very remarkable work in this field. Very warm welcome to you, sir. A very warm welcome to Dr. Radhika Bavle, Head of the Department of Oral Pathology and Microbiology, Krishnadevaraya Dental College and Hospital. So, ma'am is going to talk to us about the newer frontiers in diagnosis of oral cancer. And see, the advances in diagnosis is what matters, because we need to pick up this very early, and like I said, if we pick it up even before it transforms to oral cancer, when it is in the pre-malignant stage, that is where we can help our patients the most. And ma'am is contributing in this regard. And also now we have newer diagnostic methods, and with the advent of technology and AI, we are moving forward in diagnosing early, and this is what is going to help the patients going forward. So I also welcome Dr. Soumya, the organizing secretary of this conference, and she is the face behind the conference, and she has conceived and organized this conference meticulously. A big round of applause to Dr. Soumya. A warm welcome to Dr. Dominic, scientific chairperson for this conference. I think he has left no stone unturned in organizing as well as bringing the scientific community together for this conference. Warm welcome to Dr. Dominic. A very warm welcome to all the heads of the department, the faculty and the students from our own faculty, as well as from across Bangalore, Karnataka and India, and also those who have joined us online. A very warm welcome to each one of you, to the Faculty of Dental Sciences, Ramaiah University of Applied Sciences. We are very, very happy to host all of you, and I hope we have a great interactive session, and this conference actually takes us forward in the right direction in our approach to towards our patients, in order to control, or we have to prevent the development of oral cancer. That is to be our focus, and we have to improve patient lifestyles and prevent them from developing deleterious habits. And you as youngsters, I think you are going to play a major role, and I think we are looking forward and we are looking at you, because you are our future, you are our representatives, And you are the ones who have to be very, very vigilant, and you should not get into any of these habits, and you should also see that either your friends, relatives, or family, or your patients do not get into any of these habits. And those who have fallen into this, they have to be counseled and encouraged to stop the habit at the earliest, because that is the way we can make a difference. So together, let us all make a difference. Thank you. Please enjoy the day and the scientific deliberations going forward. Thank you, one and all.
Thank you, ma'am, for such a detailed welcome address. I now request Dr. Soumya SV to formally welcome our respected Dean, Dr. Kavita Prasad, ma'am.
Now, we kindly welcome our Organizing Secretary and Head of Department of Oral Pathology, Dr. Soumya SV ma'am, to enlighten us on the objectives, scope and essence of the National Oral Cancer Conference 2025.
A pleasant morning to one and all. On behalf of the organizing team, I would like to extend a warm and cordial welcome to all the dignitaries, invited speakers, faculty members, online and offline delegates, and participants to the National Oral Cancer Conference 2025, organized by the Department of Oral and Maxillofacial Pathology and Oral Microbiology and Oral Cancer Research Center, Faculty of Dental Sciences, Ramaiah University of Applied Sciences. This conference focuses on the theme Current Trends in Oral Cancer, Diagnosis, Investigations, and Management. The conference aims to provide a dynamic academic platform for the exchange of knowledge, recent advances, and best practices in oral cancer care. We are honored by the presence of our esteemed university leadership and eminent speakers whose guidance and expertise will greatly enrich today's deliberations. The scientific proceedings comprise a series of keynote lectures delivered by eminent speakers in oral medicine, oral oncosurgery, and oral pathology. The first keynote lecture on management of leukoplakia and lichen planus from conventional protocols to novel therapeutics will be addressed by Dr. Srinivas K., who is a consultant oral physician and dental surgeon at the Department of Dental Medicine, Manipal Hospital, Bengaluru. This will be followed by another informative session on oral cancer and its management by Dr. Nadeem Al-Hoda, who is heading the Department of Oral Oncology, Kidwai Memorial Institute of Oncology, Bengaluru. And the third interesting keynote lecture on the topic Diagnostic Oral Pathology, Evolving Science with Emerging Frontiers will be delivered by Dr. Radhika M. Bavle, who is heading the Department of Oral and Maxillofacial Pathology at Krishna Devaraya College of Dental Sciences. These lectures will focus on the management of oral potentially malignant disorders, contemporary approaches to oral cancer care, and advances in diagnostic oral pathology. These sessions integrate conventional clinical protocols with the emerging diagnostic and therapeutic modalities, offering evidence-based insights relevant to both academic as well as clinical practice. An e-poster presentation session forms an integral part of the proceedings, providing a platform for the undergraduate and postgraduate students, researchers, and faculty members to present original research, reviews, and clinically relevant case studies. The session facilitates academic interaction, critical appraisal, and constructive feedback, fostering research aptitude and scientific communication skills among the participants. So, interactive discussions following each scientific session promote meaningful engagement between the speakers and the delegates. And finally, the conference proceedings will conclude with an awards and valedictory session recognizing the outstanding scientific contributions and active participation both online and offline. Overall, the National Oral Cancer Conference 2025 reflects a collective academic effort towards advancing knowledge, strengthening diagnostic and management practices, and promoting collaborative initiatives aimed at promoting oral cancer outcomes and community health. We look forward for a day of meaningful scientific discussions and collaborative learning. Thank you.
Thank you, ma'am, for your insightful address. We now proceed to one of the most important academic highlights of the conference, the release of the abstract book. This abstract book is a testament to the collective intellectual efforts of researchers, clinicians, and students participating in this conference today. It brings together over 200 plus abstracts composed of diverse scientific contributions that reflect the current challenges, innovations, and future directions in the field of oral cancer.
To release the abstract book, it is our privilege to introduce the guest of honor for today's occasion, Mr. S. Ashok Rao sir, Registrar, Ramaya University of Applied Sciences. He has made significant contributions to the university through his leadership and academic administration. As the member secretary of the Board of Management, he has played a pivotal role in strengthening institutional frameworks, streamlining academic and administrative processes, and supporting the university's growth in research and innovation. His commitment to transparency, regulatory excellence, and development has been instrumental in advancing the academic standards and operational proficiency of the university. We are honored by your presence, sir. Thank you so much. Thank you, everyone. It is my privilege now to introduce the captain of the ship, a distinguished professor of material sciences. He holds a MSc and PhD in solid-state materials. He has made remarkable contributions through his innovative research. With over 250 research publications, invited lectures, research grants from national and international agencies, and successful supervision of 33 PhD scholars, his academic legacy is truly commendable. He is a recipient of several prestigious honors and has been serving as the Vice Chancellor of Ramaya University of Applied Sciences since 2021. He is none other than our own Honorable Vice Chancellor, Professor Kuldeep Kumar Raina, sir.
Ladies and gentlemen, please put your hands together and join me in welcoming our Vice Chancellor to address the gathering.
Wonderful MCs. I appreciate you. Namaskara and very good morning to all ladies and gentlemen. There is a saying, Paul Cole. Both these young ladies say so much about the people. I don't know whether we are worthy of same or not, but we always feel that we contribute a bit towards the knowledge domain when we deal with the students. You are the best always. Thank you very much. Thanks, Nitya and Jabdada. So, with me on dais, Mr. S. Ashok Rao ji, a good friend, a colleague, the Registrar of Ramaya University of Applied Sciences, Dr. Prasad, the Dean of Faculty of Dental Sciences, our very special and the distinguished resource persons. Thank you very much, Dr. Srinivas, Dr. Hoda, and Dr. Radhika, for sparing your valuable time with us. I know the professionals are busy, but your commitment towards education and sharing the knowledge domain with these young minds, we are so grateful to you and acknowledge your sparing time to be with us. My very good friends, Dr. Somia, Dr. Dominic, all heads of departments, Dr. Silju, the former Dean of Faculty of Dental Sciences, the members of the faculty who have come from different institutions, very beloved professionals in the Faculty of Dental Sciences at different institutions across the country. That's what it makes national. And those who could not make it to be with us in physical presence and are connected with us in the blended mode, I, on my personal behalf, on behalf of our Honorable Chancellor, Dr. M.R. Jairam, and the whole of the Rovas fraternity extend you a very, very hearty welcome. Abhinandan and Swagat to each one of you. Most of the functions I have been attending in the Faculty of Dental Sciences, where they're on the third floor of the Faculty of Dental Sciences, or sometimes when it gets slightly extended with more precincts, and then former dean and the current dean, they say, let us go to the auditorium. But today I understand the limits of knowledge in the Faculty of Dental Sciences. Elastic limits are getting expanded because we came to a place which is our Dwarika Auditorium. And Dwarika has been also very, very well known to us who are the sons of the soil. Dwarika Dish, Dwarika, the kingdom, isn't it? So my friends, I also extend you a hearty welcome to be in this beautiful auditorium, which is Dwarika Auditorium, where you can discuss, deliberate, work, network, rework, and also express the knowledge that you have accumulated over the years. Thank you very much, the Faculty of Dental Sciences and the Dean of the Faculty of Dental Sciences, for extending the limits of the knowledge horizon. Friends, we at Rama University of Applied Sciences are always keen to share knowledge. And in that context, over the years, I will not go in details, but I can only say refer to www.msruas.ac.in. It will give you the whole information that what we do, offering around 135 programs in different specialized domains. And when it comes to the Faculty of Dental Sciences, we have a legacy of more than 3.5 decades to work with the people, work with the society. And our alums who have studied from the beautiful portals of this great campus have scattered, got diffused into the society, are making us proud. An attempt to organize this level and magnitude of national conference on the apt topic, which is, I think, a relevance and concern to each one of us. What is it? The theme is current trend in oral cancer diagnostics, investigations, and the management. I think each one of them are not different specializations, but integrated way, integrated approach to look at the problems that the society is facing today. I am confident that our very invited and the distinguished resource persons will leave no stone unturned in trying to convince you, make you believe in the knowledge domain they have acquired over the years in different roles. As students, we accumulate knowledge. As teachers, we sometimes try to diffuse the knowledge. And when we reach to a level, I think we create the knowledge. So diffusion of the knowledge, dissemination of the knowledge, creation of knowledge is one of the hallmarks of each one of us in the faculty domain, and it helps the society at large to gain many things. In the last few days, I am sure you must have listened to the news that there is going to be a kind of a new Viksit Bharat regulatory committee is coming in. Have you heard about it? And the purpose is the unification from diversification, how we can funnel it into the knowledge domains where we have not to go to A, B, C, D to Z, but can we work together as a team to solve the problems of nation? Because our objective to make Bharat Viksit is not only a top-down approach, but I think the bottom-up plays a very, very important role in it. In the science and technology of the health sciences, dental science plays a very important role. I don't know whether you chose the profession by choice, by passion, compassion, or by compulsion. Because examinations, ranks, and all those things, when at times I address the new batches during the induction cum orientation program, I always say, you got what you deserved, because this is the profession which is going to make smile, each one of us smile, bring happiness on the faces. God forbid, if I take a case study, if someone has a toothache, have you seen someone smiling when he has toothache? young guys, no. So who makes us to smile? It is people like you. Even if there is toothache, you always give a healing touch, human touch, the professional touch to bring that happiness on his or her face. If that is the case, are you doing a good job? Are you in a profession which was in need for you and you were also the most apt person in that? I would say yes. Be optimist. Friends, if you look at the global population, we are more than 8 billion people. If you look at the population of our great nation, we are, people say, 1.4 billion people, plus minus. And if we see how much professional touch we can give to each one in the society, I think we still need professionals. I touched this because there's a rumor going on left, right, and the center. Jobs, there is no scope for this. People are shrinking. If people are shrinking, how is our population increasing? That means there is some mathematical algorithm which probably we are not fitting well into the system. India has 3 different domains. One, urban India, rural India, and there is another domain we say semi-rural, semi-urban. And if you look at the reach of the professionals like you, I think you have a great scope, great opportunity to serve the motherland, to serve the nation, and make everyone to smile. I don't know if you have gone around 100, 150 kilometers away from the Bengaluru city or other major cities. Have you ever got a chance to go to the extreme rural areas where they don't know what the toothache is, where they don't know? They use all herbal techniques to make them feel relief from the pain. And in that context, job opportunities are not limited, my young friends. Your knowledge, your expertise, and during this 4 years time period of your undergraduate program at BDS and more than 2 years at the MDS level is making you a professional, not only to serve yourself, but we are born to live, we are born to serve the society. In that context, please help the society, please help the nation to bring smile on the faces. We have rural women, we have rural men, we have urban men and women together. Do you see that? Have you any statistics? How many people are today suffering from the oral disease? Forget about the cancer. Our smell is the first impression of our good health. You may use any tests, but you feel whether I am good or bad, whether I can improve upon or not. So in that context, the health diagnostic starts from the mouth itself, and that is where you are going to play a very, very important role. At Faculty of Dental Sciences in the Ramaiah University of Applied Sciences, my friends, we offer 9 different postgraduate specializations, and in addition to that, every faculty member, every employee, every student is so devoted and dedicated that it is in learning, learning, and learning. If you look at the theme, oral cancer, people used to say sometimes it is tobacco, which makes us to get closer to this oral cancer. But I have seen and came across some literature as well. There are women who don't smoke. They also have this problem. Is smoke the only problem? Is pan, gutka the only issue? They may be aggravating certain problems. I think it is the virus within each one of us, how we can protect it. And for that, good health, good hygiene, good food, and good attention is very important. In the developed world, they also have these problems. It's not only that India or the South Asia is facing these kind of typical situations. These are global problems. But what they do is, there is a frequent periodic checkup for the tooth. And in India, including me, I speak from the podium, it is only when I feel toothache I go to the dentist or go to the specialist. There is no such process. Can we have the periodic checkups? It is not always you have to go to a specialist, to doctor, when you are ill. I think there are certain pre-diagnostic tools as well. I think the awareness to be brought in the public domain is very, very important. I request the Faculty of Dental Sciences and Dean, Dr. Kavita Prasad, can we make it possible? No doubt, we have the rural health science program, we do many things. But let us look at that, stretching that boundary as well, Dr. Kavita. Then let us look at the people. And these young students are going to play a very, very significant and important role in that direction. Let us bring in. If we are in a position to reduce the health problems, especially when it comes to the oral cancer, by 1% in a year, I would say we are fulfilling the dream of this seminar, this national event, because it should not get escalated. Let us try to recline it. In this mode, I think that is what the challenges are, that is what the importance we can play, the role that we can play for developing the Viksit Bharat. My friends, we all and you too are at a threshold when the global technology scenario, global knowledge scenario is changing. And in that, what can you do the best, collectively as well as individually? In this, such platforms where we discuss and deliberate with the expert panel, I think that is where we can create new knowledge. And one more thing, if you get some idea, please don't put it to yourself only, don't put it close to the chest, express. Because these experts who are bringing over 3 decades, 2.5 decades of experience may have a solution. If there is no solution existing at the moment, I think this probably may give us a solution for futuristic approach. So in that direction, I compliment the Faculty of Dental Sciences for taking such initiatives and associating the Faculty of Dental Sciences of our university with the national community to bring in awareness. I'm sure the day is not far away because 1st January 2026 is coming soon. I set a deadline, as I always say in the meetings as well. Can we have an international conference from the Faculty of Dental Sciences next year? I know one conference is in the plan, sometimes in the month of June, July. The team is working on it. I am aware about that. Maybe thereafter could be November, December 2026, because an international conference of very high quality, very high presence and eminence needs a time period. So let us start working from today, which is 17th of December 2025, and let us freeze the date. Can it be on 1st of December 2026? Whether you get an invitation or not, but today I am inviting each one of you to become a part of that Mahakumbh, where the knowledge that we have gained, not only through Google Guru, but from your gurus too, and your efforts in thinking differently, we can put it. And the release book will be the contributions of our very beloved students across the international fraternity. One. Second, there is a very important continent which we miss at times. That is the African continent. I think they have their own concerns. There are many issues. They are doing good, great resources. But can we help them to get the better health care, especially when it comes to the dental sciences? I request all faculty members, please look into this holistically and see that can Ramaya University of Applied Sciences and the Faculty of Dental Sciences make it possible. I see more ways of saying yes than saying no. Let us say yes, yes, and yes. With these words, I wish you a Merry Christmas and a very Happy New Year 2026. I'm sure we all will work together to make tomorrow the best. Feel everyone and try to make efforts in eradicating the oral cancer from the society as soon as possible. Let us all live happily. And we always pray, Sarve Bhavantu Sukhna, let everyone feel happy, let everyone get good health, and for that, any contribution that the society needs from our Faculty of Dental Sciences, we are always with you. I wish you all the best, great luck, discussions, deliberations, and the brainstorming. Jai Hind, Jai Karnataka. Thank you.
Thank you very much, sir, for the inspiring, exciting, and insightful address. As we draw the inaugural ceremony to a close, it is time to express our gratitude to everyone who made this event possible. We now invite Dr. Dominic Augustine, Scientific Chairperson, NOCC 2025, to deliver the vote of thanks.
Good morning, all. On this momentous occasion of the National Oral Cancer Conference 2025, it is my esteemed privilege to express my profound appreciation to the distinguished dignitaries who have graced this occasion. First and foremost, I would like to extend our gratitude to our Honorable Chancellor, Dr. M.R. Jairam Sir, and the management. I sincerely thank our chief guest, Honorable Vice Chancellor, Dr. Kuldeep Kumar Raina Sir, for his continued encouragement, unwavering support, and constant motivation. His visionary leadership and guidance have significantly contributed to fostering an environment of academic excellence, innovation, and professional growth, motivating us to strive for higher academic standards. Thank you, sir. Dear sir, we had initially planned to host this event, like our dean mentioned, for 250 participants. However, the response has been truly overwhelming, with registrations crossing 450, and nearly 300 delegates are attending in person today. This remarkable turnout clearly reflects the strong enthusiasm of the academic community and their keen interest in visiting Ramaiah University of Applied Sciences, reaffirming the institution's growing presence, credibility, and standing in the academic fraternity. I sincerely thank our esteemed guest of honor, Mr. S. Ashok Rao Sir, Registrar RUAS, for graciously accepting our invitation and honoring us with his presence. His willingness to be part of this event has truly made this a memorable occasion for us. Thank you, sir. I thank our Provost, Health and Allied Sciences, Dr. G.S. Venkatesh Sir, for his invaluable guidance, constant support, and encouragement. I thank our beloved Dean, Dr. Kavita Prasad Ma'am, a lady of few words but profound action. With quiet determination and unwavering commitment, she leads by example, translating vision into meaningful outcomes through consistent effort, integrity, and purpose. Thank you, ma'am. I thank Dr. Soumya S.V., Organizing Secretary, NOCC 2025, and my HOD, for her relentless commitment and pivotal support. Thank you, ma'am. I thank our esteemed speakers, Dr. Srinivas K., Dr. Nadimul Hoda, and Dr. Radhika Bavle, ma'am, for graciously accepting our invitation, and they'll be sharing their valuable time, expertise, and insights. I thank our Master of Ceremonies, Dr. Hajira Katun, and Nitya Ganeshan, for gracefully and efficiently conducting the proceedings of this program. I thank Dr. Surendra for coordinating the events of NOCC 2025. I thank Mr. Gopalakrishna Sir for his invaluable assistance and wholehearted support in managing the various logistical requirements of this event. His willingness to go the extra mile has ensured all arrangements were handled efficiently. I thank Mr. Anthony, Manager Program Operations, Mr. Vijay, Ms. Veena, Mr. Nagesh, and the Photography Club who are present here for the lively audiovisual arrangements. I also thank Mr. Krishnaraj Shetty and his team for their presence. A special word of mention to our FDS student organizers, I don't call them volunteers, but student organizers in various committees whose determined efforts have made this day possible. My heartfelt thanks to the Departments of Oral Medicine and Radiology and Department of Oral and Maxillofacial Surgery for their continued support for this event. Thank you, dear HODs of Faculty of Dental Sciences and my dear faculty members of FDS for attending this inauguration. Your presence here means a lot to us personally. Let's carry forward the spirit of collaboration, the desire to excel, and the promise to build each other. Thank you all for being part of this memorable event. Thank you once again.
Thank you, sir. May we request everyone to kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पञ्जाब सिन्ध गुजरात मराठा द्राविड उत्कल वङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधि तरङ्गा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. Please take your seats. With this, we conclude the inaugural ceremony of the National Oral Cancer Conference 2025. We request all our dignitaries, faculty members, delegates, and participants to kindly proceed towards the high tea area for refreshments. We further request everyone to kindly assemble back in the auditorium by 10:45 to commence with the keynote lecture session.
Thank you all for your gracious presence, and we wish you an engaging and enriching conference ahead. Thank you.
Check. Yeah. Respected delegates, we request everyone to kindly be seated. We will be proceeding with the keynote lecture very soon in maybe 2 minutes. Let them sit. We request everyone to settle down.
We now invite you to turn your attention to the keynote lectures, where expertise meets experience and ideas translate into impact.
It is my pleasure to introduce our moderator for the first keynote lecture of the day, Dr. Sujata S. Reddy ma'am, Professor and Head, Department of Oral Medicine and Radiology, Faculty of Dental Sciences, Ramaya University of Applied Sciences. With over 24 years of rich clinical and academic experience, Dr. Sujata ma'am has made remarkable contributions in the area of tobacco control, oral potentially malignant disorders, oral cancer research, and salivary diagnostics. Her extensive research on salivary biomarkers, including volatile organic compounds and salivary exosomes, has significantly contributed to the early diagnosis and prognosis of oral cancer. She has co-authored academic books, contributed chapters to textbooks, and her research work has received competitive grants and patents. She is the recipient of several accolades, including the Best Teacher Award in 2022 and recognition as Outstanding Professor at MS Ruas, and holds the distinction of being the first to establish an exclusive tobacco cessation clinic in a dental college in India.
Please join me in extending a warm welcome to Dr. Sujata S. ma'am to moderate the first keynote lecture of the day by Dr. Srinivas K.
Ma'am, the stage is yours.
Thank you for the kind introduction, and for the opportunity. A very good morning to one and all. It's a moment of honor and privilege to introduce a distinguished clinician and a very good friend of mine, academician and a leading authority in the field of oral medicine and radiology, Dr. Srinivas K. Dr. Srinivas K is an exceptionally qualified and experienced oral medicine specialist with mastery across multiple domains of oral medicine and radiology. He completed his Bachelor of Dental Surgery from the College of Dental Sciences, Davangere, Karnataka, and went to pursue his Masters in Oral Medicine and Radiology from the PMNM Dental College, Bagalkot, Karnataka. Dr. Srinivas has been awarded the prestigious fellowship of the Royal College of Physicians and Surgeons, Glasgow, and has also completed a diploma in temporomandibular joint disorders and headaches from the United Kingdom, reflecting his advanced training and international exposure. He has been active and a committed member of several esteemed professional organizations, including the Indian Academy of Oral Medicine and Radiology, the Indian Dental Association, and the American Academy of Oral Medicine, and also the European Association of Oral Medicine. A clinician par excellence, Dr. Srinivas created a milestone in oral health care by becoming the first to establish an exclusive oral medicine practice in South India in March at the Manipal Hospital, HL Airport Road, Bangalore. He is widely recognized for his expertise in the management of oral ulcers, oral potentially malignant disorders, temporomandibular joint disorders, facial pain, burning mouth syndrome, salivary dysfunction, and oral manifestations of systemic diseases and management of medically compromised patients. So I'll be moderating this session by Dr. Srinivas on the topic management of leukoplakia and oral lichen planus from conventional protocols to novel therapeutics. So even today, oral lichen planus and leukoplakia are a clinical challenge. It's been for its malignant potential and the chronic immune dysregulation. Traditional treatment still remains the backbone and it's widely used across, but recent advances in molecular biology, immunotherapy, biologics, and minimally invasive technology are offering more targeted, effective, and less invasive options, improving patient outcomes and personalized care. So with this brief introduction, I invite Dr. Srinivas to share his valuable insights on this topic.
Good morning, one and all. Thank you, Sujata ma'am, for that nice introduction. We all being dentists, the theme of today's conference is oral cancer, but majority of the people are not as fortunate as Dr. Nadeem, who gets to directly deal with oral cancers. So majority of the time, what we see is, and what we commonly encounter, is the potentially malignant disorders, and many people are not aware of what exactly are these diseases and how to manage them. So the reason I have chosen these two topics are, these are oral potentially malignant disorders which requires special attention. If you stop these diseases, definitely you can stop oral cancer. That's why I have chosen this topic. India accounts for 1/3 of all oral cancer cases worldwide and 30% of all cancers. According to Globocan 2022, India reported these many cases of oral cancer with the age standardized incidence rate of 9.9 per 1 lakh people, which is very high, and it makes India one of the countries with the highest burden of oral cancers worldwide. And the most important thing, oral malignancies are preceded by asymptomatic, clinically noticeable oral lesions known as oral potentially malignant disorders, with a significant concern with rate ranging from 2.3 to 8% is the malignant transformation rate. It depends on disease to disease, but majority of these OPMDs are asymptomatic and a proportion of them may transform to oral squamous cell carcinoma, and they serve as surrogate clinical lesions to identify individuals at risk of developing oral squamous cell carcinoma. The problem with treating these diseases in India is scarcity of scientific evidence on specific intervention and management of oral potentially malignant disorders. So I have picked up 2 diseases. Let us see how to intervene, diagnose and manage these kind of diseases. Now we all see mucosal lesions in our practice. See, the presentation that I am going to cover, I am told that the audience is an admixture of UGs, PGs and faculty. I have tried. I have not covered too much basic and I have not covered too many advanced aspects also. I have tried my level best to make it very, very simple. In general, when anyone sees a mucosal lesion in a general practice, I don't like the attitude which they look at it. They don't classify or try to diagnose the disease. Instead, they start prescribing these things. I have serious reservations about this practice and I appreciate the opportunity to discuss how it might be improved. Mucosal lesion is not just an alteration, should not be managed with topical steroids every time. Then how do you manage? We don't have specific guidelines to manage oral potentially malignant disorders. We have an excellent academician par excellence in India. His name is Dr. Praveen Birur. He heads Kale Institute of Dental Sciences in Bangalore. He is a well-known researcher worldwide. So he invited about 52 clinicians from all over the world. They had a consensus guidelines meeting, and in the year 2022, they came out with the consensus guidelines on the management of oral potentially malignant disorders pertaining to India. Every student has to go through this article so that you should know how to manage these conditions. And about 50 to 60% of times we follow these guidelines, and there are some situations where we don't follow these guidelines. I'll also discuss them when I'm discussing the diseases. So first we will move on to the first disease, that is leukoplakia. The definition of leukoplakia has transformed from 1988 to 2008 and 2015. The latest definition says it is a white plaque of questionable risk for malignant transformation, having excluded other known white lesions or disorders that carry no increased risk for cancer. So it is just simply a non-scrapable white patch that has increased potential to transform into a cancer. It is a diagnosis of exclusion. What does it mean? Diagnosis of exclusion means we have to exclude other white patches which are not leukoplakias. So for the benefit of UGs who are sitting here, I have just put up these. What are all the things that we need to exclude? Don't read this. Alveolar ridge keratosis, aspirin burn, thrush, Darier's disease, frictional keratosis, geographic tongue, hairy leukoplakia, leukedema, lichen planus, linea alba, lupus, morsicatio. Let's see one by one. When a patient is edentulous because of the friction from the foot, there is keratosis. This is alveolar ridge keratosis. Don't confuse this for leukoplakia. This is a chemical burn. You can see this is a scrapable white lesion. You can see a pseudomembrane here. Generally, chemical burn happens in Western countries because whenever they have a toothache, they keep aspirin tablet inside the mouth. In India, it happens because they keep clove. Most of the times, either clove or a cotton dipped in clove oil. That is when you get to see chemical burn. This is not leukoplakia. This is a classical scrapable pseudomembranous lesion in the palate. This is your pseudomembranous candidiasis. Definitely not leukoplakia. This is Darier's disease. This is Darier's disease. Darier's disease, also known as keratosis follicularis. Primarily, palatal and alveolar mucosa are involved. Asymptomatic, multiple white papules, and this cobblestoning appearance is classical for this Darier's disease. Along with that, what you get to see is also skin lesions. So you can't miss this. What is this? You can see sharp wisdom teeth, traumatic keratosis secondary to sharp wisdom teeth. Linea alba buccalis. Linea means line, alba means white, buccalis present in the buccal mucosa. It's a white line which is a normal variant seen in about 30 to 34% of normal population. Don't confuse it with leukoplakia. Another linea alba buccalis. Sometimes it terminates in a Y-shaped fashion. Leukedema. What is leukedema? It is a blue, gray or white appearance of mucosa, particularly the buccal mucosa. And how to recognize it? It has a classical feature. When you retract the cheek, it disappears. When you relieve it, it reappears. This is leukedema. Fordyce's granules, collection of sebaceous glands in the oral mucosa. This is again a normal variant. Lichen planus. You can see the classical Wickham's tree. What you are seeing here, a reticular pattern of papules intermingled with erythematous and hyperpigmented patches. classical reticular lichen planus. And this is morsicatio. Morsicatio means cheek biting. A person who has got chronic cheek biting, you can see the bite marks here. With that, the mucosa is getting exfoliated. So once you exclude all these things, then you arrive at a diagnosis of leukoplakia. An exception is there will be a history of smoking, which is an etiological or an exacerbating factor. So what is the natural history of leukoplakia? It can be associated with smokeless or smoking tobacco. About a decade back, people were using the terminologies called as tobacco pouch keratosis. Now they all have been grouped under a single terminology. It is called as leukoplakia, either associated with smokeless or smoking tobacco. Tobacco and aracanate usage. Alcohol acts as a synergistic factor. A leukoplakia may be asymptomatic or symptomatic. When you talk about the therapeutic strategies for leukoplakia, most important point to remember, if a leukoplakia is measuring more than 2 centimeters, and if it is non-homogeneous, it is always colonized with Candida albicans. What are the types of leukoplakia? Homogeneous, non-homogeneous, which can be nodular, speckled, and verrucous, and exophytic. So let us see the clinical pictures. A homogeneous leukoplakia is a non-scrapable white patch. You can see it on the buccal mucosa, tongue. It has got a consistent pattern throughout. If you just see, there is a sharp demarcation between normal mucosa and the white patch, a consistent pattern throughout. The appearance has been described as cracked mud appearance. This is how homogeneous leukoplakia appears. Homogeneous leukoplakia, dorsum of the tongue, lateral border of the tongue. Non-homogeneous leukoplakia, you can see along with the non-scrapable white patch, there are red lesions. This is a speckled leukoplakia. This is a speckled leukoplakia, dorsum of the tongue, non-scrapable white lesion intermingled with erythematous areas. Again a speckled leukoplakia, left cheek. This is a pan chewer, this is a gutka chewer, this is a bidi smoker. And this is a verrucoid appearing lesion in the palate, verrucous leukoplakia in the palate. These are the types of non-homogeneous leukoplakia. So when you see these kind of patients in the clinic, the first thing that we need to do is risk profiling. You will have to divide the case of leukoplakia into low risk and high risk. How do you do that? If the lesion is less than 2 centimeters square, if the lesion is less than 2 centimeters square, if it is a homogeneous type of leukoplakia, if it occurs in any site in the oral mucosa except for the tongue and floor of the mouth, you label it as low risk leukoplakia. If the lesion size is more than 2 centimeters square, if it is non-homogeneous, if it affects the tongue and floor, if it is affecting the females, especially if it is not associated with any habit, if the age of the patient is more than 40 years, if there is a family history of cancer, and if it is non-habit associated, you will have to label it as a high-risk leukoplakia. Now, if you look at the malignant transformation rate, it is about 7.2%, and the previously published range is about 3.5 to 9.7%, which is very, very high. Now, how do you manage? The moment you term it as a low-risk leukoplakia, first is cessation and counseling. In my clinical experience, normally people do not strictly follow the guidelines given by tobacco cessation or psychologists. So nowadays we are directly referring them to psychiatry for tobacco cessation. As I told you, any lesion measuring more than 2 centimeters square, there is a fungal colonization. So when you start the treatment, you start with a topical antifungal. Clotrimazole, which is available as a candid gum paint. You can ask the patient to use it on the patch, apply, leave it for 5 minutes, and then rinse his mouth at least twice a day for a period of 7 days. That clears off the fungal colonization. Then topical vitamin A, 25,000 international units twice a day for 90 days. My dear friends, topical vitamin A in an oral cream form is not available in India. There are vitamin A gelatin capsules which are available in the market. So you have to ask the patient to puncture the gelatin capsule, express the contents onto the index finger, and then apply it onto the lesion, leave it for half an hour, and then rinse his mouth. This is how you'll have to ask him to apply topical vitamin A. Then 75 grams of green leafy vegetables per day, guava and papaya eating to be made compulsory, and what is most important is regular surveillance. When it is a high risk, remember we divided it to low risk and high risk. The moment you see a high risk leukoplakia, first thing you need to do is biopsy. The guideline from this particular article headed by Dr. Praveen says biopsy. What we are following in our hospital is complete excision. We are surgically excising it with carbon dioxide laser. I'm showing you pictures of cases treated with topical vitamin A. You can see a non-scrapable white patch here. This is after 2 months. Kine chewer. You can see leukoplakia here after 2 months after treating with, of course, cessation is number one. Patient has stopped the tobacco habit and then topical vitamin A application for 2 months. Another patient, you can see leukoplakia, left buccal mucosa before and after treatment with topical vitamin A. Now, you all must be knowing that there are a lot of oral cancer cases which are not associated with tobacco habit. They are non-habit associated cancers and they are more aggressive as far as their clinical behavior and the response to treatment is concerned. Likewise, we are also seeing leukoplakias which are not associated with any habit and which are more aggressive as far as the malignant transformation is concerned. So I am showing you a case, non-habit associated leukoplakia, ventral surface of tongue, lateral surface of tongue, highly progressive condition. So the moment these cases come, excision, follow-up. Most important thing that you need to follow here is adopt a more proactive follow-up approach and maintain heightened diligence in follow-ups. The importance of follow-up, I'll show you one case. This patient came to us in 2017 with a lateral border tongue leukoplakia. It was biopsied, it showed no dysplasia. We kept following up the patient. In 2023, he comes with a large leukoplakia on the right lateral border of the tongue. In 2023, when it was operated, there was high-grade dysplasia. Therefore, most important thing is follow-up. And how do we follow up the patient? Once a dysplastic lesion is excised, in the first year, you'll have to follow it up once in 3 months. In the second year, you'll have to follow it once in 6 months. And after second year, at least once in a year, you'll have to see the patient and evaluate. Now I'm going to tell you a most dangerous form of leukoplakia, that is the proliferative verrucous leukoplakia. In my 24 years of practice, the first 22 years I have seen 3 cases of proliferative verrucous leukoplakia. In last 2 years, we have seen 7 cases of proliferative verrucous leukoplakia. So things are changing. Lot of immune dysregulation, environmental factors have been changing, and all the diseases are behaving like this. The importance of knowing this disease is you'll have to treat it very, very aggressively. It is a kind of leukoplakia with greatest degree of malignant transformation. The rate is 43 to 65%, and the recurrence rate is about 67.2%. It is more commonly seen in women and lower gingiva. And most of the times, clinical behavior does not match the histologic features. It is again a non-scrapable white patch which has got a verrucoid appearance. So when you take a biopsy of that, the pathologist gives a report of hyperkeratosis without dysplasia. But my dear friends, let me tell you, this is how it looks. You can see a gingival non-scrapable lesion here and here and here. This is the same patient after 2 months of excision. This is 6 months follow-up. He has already developed a squamous cell carcinoma. You can see it in this particular alveolus here. There is nothing over here at the initial diagnosis, but after 6 months, he has already developed squamous cell carcinoma. Out of those 9 patients that I have seen, 2 patients have already developed squamous cell carcinoma. It is very, very extensive lesion. You can see gingiva, labial mucosa, buccal mucosa. It is extending till the retromolar trigone. This is how a proliferative verrucous leukoplakia appears. Another case of proliferative verrucous leukoplakia. This part was biopsied and it has already turned into squamous cell carcinoma. So how do you manage this proliferative verrucous leukoplakia? Since it has a potential to undergo malignant transformation over time, Whenever you see a lesion, carbon dioxide laser. And periodic surveillance, every 2 months you will have to call the patient, recall the patient and examine for new lesions. And if new lesions have come, again, carbon dioxide laser excision or scalpel excision, whichever the surgeon is comfortable with. With this, I finish leukoplakia. We will go to the next disease, oral lichen planus. Oral lichen planus is the commonest mucosal disease that we encounter in oral medicine practice. Majority of the times, there are no management protocols, no convincing evidence that one treatment is better or worse than another. And what we have observed is there is a change in the disease pattern. There are many clinicians who still believe that lichen planus is not a potentially malignant condition or a disease. Lichen planus has been recognized as an oral potentially malignant disorder right in 2005 by the WHO Collaborating Center for Oral Cancer. And this is the most recent systematic review which says it has got good amount of malignant transformation, headed by none other than our Don in OPMDs, Dr. Saman Varnakula Surya. So so with this, I think everybody believes that lichen planus is a potentially cancerous disease. So what is lichen planus? It is a unique cutaneous entity consisting of an eruption of papules, distinct in color, configuration, patterns of location of appearance, and in microscopic as well as gross structure. Please remember, in lichen planus on the skin, you will see purple polygonal pruritic papules. Pruritus is there, purplish hue is there, polygonal in appearance. These are basically papular lesions that you can see in the skin. Let us not go into the details of this. I would explain this in very simple manner for you people. We all know that anything that enters the human body has to be picked up by an antigen presenting cell. The antigen presenting cell has to present it to the lymphocyte. Lymphocyte recognizes that and kills or neutralizes or whatever. This is how the immune system works. If the lymphocytes are directly not working properly, you will term it as an autoimmune disease. A T lymphocyte attacking a serous acini of the salivary gland is termed as Sjogren's syndrome. But here it is not like that. People have realized that there is a mutation of the antigen presenting cells. So the mucosa or the skin itself is being presented to the T lymphocyte as a foreign substance. Because of that, our own cells are our own white blood cells are destroying the cells of the oral mucosa or the skin. As a result of that, you are getting lichen planus. If body is restraining this particular thing, if it is trying to control the disease by expressing more keratin and melanin, you will get to see white patches and black patches. If body is unable to restrain the disease, there is a basal cell degeneration. Because of that, there is atrophy, erosion, ulceration, loss of epithelium. That is what you see in lichen planus. Very, very simple. Immune system mediated disease. What are the types of lichen planus? Number one, reticular lichen planus. The classical reticular pattern, I showed you this picture earlier. In annular lichen planus, what you see is round shaped lesions, plaque type of lesions resembling homogeneous leukoplakia, pigmented lichen planus. There is a concept in oral cavity called as post-inflammatory pigmentation. Any inflammatory disease in the mouth, when it heals, body puts up more amounts of melanin as a response to inflammation. So even when lichen planus heals, the areas in the mouth where you had seen active lesions, when it heals, you will get to see pigmentation. This is pigmented lichen planus. And the most dreadful forms of lichen planus, the erosive lichen planus. You can see the difference between erythematous lichen planus and erosive lichen planus is erosion means moist red. You can see moist red patch here, erosive lichen planus, and this is a bullous lichen planus. You can see the sloughing as a result of ruptured bulla. Most of the bullous or vesiculous diseases, you can't see the intact vesicle in the mouth because we are always subjecting the areas of the mouth to constant irritation and pressure because of masticatory forces. A vesicle appears immediately, it bursts. What you get to see is an erosion or a sloughing like this. Or probably if it is a very, very subepithelial bulla like what we see in a disease like cicatricial pemphigoid, you might get a chance to see a particular bulla inside the mouth. But most of the times, This is what you get to see in bullous lichen planus. And last form of lichen planus, very, very, very difficult to treat, that is the desquamative gingivitis caused because of lichen planus. The gingiva is desquamated, but again you will get to see somewhere the intermingling of papular lesions here and there. This is again lichen planus. You can see papular lesions, desquamation of gingiva here. How to treat it? Please remember, biopsy is mandatory unless it is a non-erythematous, non-erosive lichen planus. Biopsy is mandatory. If it is erosive, if it is erythematous, biopsy is mandatory. And you will have to do the basic blood workup when you start to treat oral lichen planus. What is the basic blood workup that you do? Subject the patient for blood counts, peripheral smear, iron studies, vitamin B12 assay. This is very, very important when you are treating mucosal lesions, my dear friends, because the mucosal integrity and the healing capacity of oral mucous membrane is very much dependent on iron containing enzymes and vitamin B12. So if the patient is suffering from a B12 or iron deficiency, you don't expect the treatment to be as effective. So when you are treating the disease, along with that, if the patient is having deficiency states, you'll also have to treat vitamin B12 and iron deficiency together, so that the response to the treatment will be optimum. Gone are the days where people used to tell if you start treating lichen planus, the disease gets cured. It's not true. It has started behaving like an autoimmune disease. There are periods of remissions and exacerbations, and patients keep coming to you again and again and again. So no therapy is curative. Goal is palliation, and the primary goal of a clinician is to reduce and eliminate pain and burning as far as lichen planus lesions are concerned. When I started my practice in 2003, there was no topical steroid available. Cash pharmacy used to import a drug called Kenalog S with Orabase from Bangkok, which used to cost 230 rupees at that time. Very, very difficult to treat, but today we have at least triamcinolone. So in my 25 years of treating lichen planus, I have gradually transformed, started with triamcinolone cream, and then I used to ask patients to buy betamethasone or dexamethasone tablets, crush them, mix it with butter, apply it onto the mucosa, and then tacrolimus cream came into picture. We started giving that, then aloe vera, then cold laser therapy, then curcumin gel. Unfortunately, none of these are working today as far as lichen planuses are concerned, especially the erythematous and erosive forms are concerned. So what we are giving is, we are giving clobetasol propionate. Unfortunately, this drug is also not available in India as an oral cream. We are getting it dispensed from a compounding pharma as an oral cream, and this is how we are treating the patients. And about 50% of erosive lichen planus patients now they have stopped responding to topical therapy. So we have started using immunomodulators, systemic immunomodulators for treating oral lichen planus. Previously, till 2010, we used to treat a patient with dapsone. Now, dapsone is basically an anti-leprotic drug, which is used as an immunomodulator. That drug doesn't work anymore for oral lichen planus. Then we started using hydroxychloroquine sulfate, which is an anti-malarial and an immunomodulator. That also is not working for lichen planus anymore. What we have started now is 3 immunomodulators we are regularly using for patients based on their general health. We are taking the help of rheumatologists, and we are prescribing patients these 3 drugs, not all 3 together. Our first choice would be methotrexate. Methotrexate, you all know, is a antimetabolite. Anti-inflammatory drugs also very widely used in the treatment of rheumatoid arthritis. We generally use methotrexate ranging from a dosage of 2.5 milligrams to 15 milligrams once a week. Once a week. Please remember, you should not directly prescribe methotrexate. You have to take proper consent of the patient. You'll have to send them to a physician. Before initiation of therapy of any of these medications, it is important for us to check ESR, blood sugar levels, liver function, kidney function, CRP levels. And please include a physician or a rheumatologist in your therapy so that they will help you in prescribing these medicines, and most important, monitoring the patients when they are on this drug therapy. They require monitoring at least once in 3 months. They need to repeat all the tests that I have enlisted, and they'll have to come back to you for these particular tests. So methotrexate is working wonders as far as lichen planus is concerned. The other drug is mycophenolate mofetil. We'll talk about it a little later. And of late, we have started using another immunomodulator. Basically, it's called tofacitinib. Tofacitinib is a Janus kinase inhibitor, which is widely used in the treatment of rheumatoid arthritis and other autoimmune diseases. Tofacitinib is given in the dosage of 10 milligrams once or 5 milligrams twice a day for a period of 3 to 6 months. And mycophenolate mofetil, we will discuss about it. I want to show you something else regarding that. So as far as management of oral lichen planus is concerned, first line of treatment would be steroids and then mycophenolate mofetil. If the patient is having an erosive lesion, please start with an intralesional steroid. When it comes to the choice of intralesional steroid, first choice should be dexamethasone. Reason, number one, it is the longest acting steroid. Number two, when you come, generally people, the moment we say steroid injection, their choice would be Tricort, triamcinolone. Triamcinolone is extremely viscous. Patients cannot tolerate the pain in spite of giving local anesthesia. This is not as viscous as triamcinolone. Dexamethasone is more comfortable, you can use them. Systemic steroids can be used in severe erosive cases, at least till the disease gets controlled. Once the disease is under control, you can switch over to these medications for sustained immunomodulation. Now let's talk about local drug delivery splint. Yeah. You all have been doing splints for bleaching, right? In a bleaching tray, you give a spacer for the teeth so that the bleaching agent acts on the teeth for management of discolored teeth. Likewise, when you see desquamative gingivitis like this, secondary to any bullous dermatosis, whether it is lichen planus or pemphigus or bullous pemphigoid, you have to do drug delivery splints like this. This is a modification of your bleaching tray. Instead of giving spacer on the teeth, we have given spacer on the gums. So you can see that the steroid is in place. This is before and after treatment. This is how you have to manage drug delivery splints. More details of this desquamative gingivitis you can read up from your textbooks. It's given very nicely. I have also written a chapter on desquamative gingivitis in textbook of periodontics by Shantipriya Reddy. More details are given and discussed there. You can go through that. Now let's talk about mycophenolate mofetil. This again suppresses dendritic cell maturation and antibody formation, and it inhibits the proliferation of activated T cells. So it is keeping the disease under control, not allowing the T cells to destroy the oral mucous membrane and cause oral lichen planus. So we thought 250 to 500 milligrams of mycophenolate mofetil was too much for a small disease like lichen planus. There are a lot of systemic side effects associated with that. So we thought, why not try a topical medication? So we contacted our compounding pharma and then we did a study. What we did was, we prepared a mycophenolate mofetil oral cream by adding Orabase, hydroxymethyl or ethyl cellulose. With topical mycophenolate mofetil, we compared it with clobetasol, mycophenolate mofetil and a placebo. And after 4 weeks, what we saw was clobetasol and mycophenolate mofetil both gave full relief. 3 had candidiasis in the clobetasol group. None of them had candidiasis in the mycophenolate group, and none of them had relapse over a period of 6 to 8 weeks. So now what we are doing is, we are starting the patients on topical steroid. Once the disease comes under control, we are shifting to topical mycophenolate mofetil, and that is how we are keeping them under maintenance. Another thing that you have to remember, I told you the disease has started behaving like autoimmune disease, so there is no end for treating this. That doesn't mean everyday patient has to use these medications. Let us say you have started a patient on a mycophenolate mofetil cream or a clobetasol cream thrice a day. In a span of 3 to 4 months, what you have to aim is, the patient has to use the drug once in a week as a maintenance therapy. So from thrice a day, you make it twice a day, once a day, thrice a week, twice a week, and then arrive at once a week. There are patients whom I have given it once in 10 days. They are on maintenance therapy. So I have spoken about desquamative gingivitis. These are the pictures where intralesional dexamethasone is given. After 2 injections, you can see all these erosive and red areas have started healing nicely. This is about the desquamative gingivitis. Now, the most important thing in lichen planus, again, periodic recall. All my patients, initially when I start the treatment, I call them once in 2 weeks. Once the erythematous lesions or erosive lesions start healing, we call them once in a month, because when it is going to turn into a malignancy, we do not know. There are some warning signs that you should keep watching. These are lichen planus patients who have suddenly developed. You can see there is a proliferative growth here, small. Here what you can see, an erosion with subtle changes here in the periphery. Please remember, a patient who is responding in a nice manner for topical or systemic therapy has stopped responding to a topical therapy for more than 2 weeks. And if you see architectural changes in the mucosal lesions, that's the time you should decide and do a biopsy, my dear friends. And the changes are so subtle that sometimes you fail to realize that it is squamous cell carcinoma. You just look at this, an erosive lichen planus here, suddenly this lesion appears and there was a small induration here. This turned out to be squamous cell carcinoma, unbelievable. So, periodic surveillance is very, very important as far as these diseases are concerned. Because of the time, I am not able to show more cases that we have treated. I am going to end my presentation in a preventive note. My dear friends, please remember there are a lot of non-habit associated oropharyngeal cancers. What do we know about that? HPV can cause serious health problems including warts and cancer. And if you look at the data, what it says is around 41% of oral cancer cavities are caused by non-habit associated cancer. They are associated with human papilloma virus. It is well documented and proven that it causes cancers in the females, especially the genitals. So it is commendable that the state government of Karnataka has already started HPV vaccination drive for 14-year-old girls. Especially in 9 mining affected districts they have started, which they are going to extend. But if you look at the guidelines given by the CDC, the Center for Disease Control, it says that even males aged 22 to 26 years may be vaccinated. I think we all should take this up seriously. HPV vaccine is very, very, very safe. Now the nanovalent vaccine is available in the market. I request all the dentists to tell these to the patients and get them vaccinated. And if you have children or siblings, please encourage them to get vaccinated for HPV vaccine. To conclude, I would like to say 80% of oral cancers are preceded by potentially malignant disorders. Oral potentially malignant disorders are identifiable. Please don't forget to do a biopsy. Treatable condition. Habit cessation is a very, very important role. As far as clinicians are concerned, management and periodic recall and review is very, very important. Because of that, prevention results in better outcomes. So if you can arrest the disease at this particular stage, there is no way we can talk about this, whether it is a habit-associated OPMD or non-habit-associated OPMD. If we strictly follow the guidelines, patient is getting the benefit, we are also happy. With this small presentation, I thank the MS Ramaya Dental College people for giving me an opportunity to talk here. If there are any questions, I am open for questions. Thank you. Yes, sir.
It was a nice presentation, sir. You mentioned about 2 modalities of treatment for leukoplakia. One is the conventional scalpel excision, other one is the CO2 laser ablation. In your experience, which has offered a better outcome?
Sir, since we are dealing with a potentially cancerous lesion, we don't look at the outcome because the entire lesion is removed irrespective of whether it is scalpel or laser.
When assessing
So
that
most important is periodic surveillance. Sir. Whatever is the technique you follow, if the patient doesn't come for a follow-up, apparently he'll get into this.
So if you have excised leukoplakia in one region, and how often it usually comes on the other site as a primary one?
I would say about 10% of them.
10% of them they comes. Thank you, sir.
Although the data is anecdotal, I don't have the authority to say so. Yes, sir.
Very good presentation, especially basic you have talked. One more thing which you have missed, I think, just this. you could have added that about erythroplakia. Erythroplakia has got highest potential to transform into malignancy.
Sir, the topic was on leukoplakia and
Yeah.
lichen planus, so I have skipped all those
But
things. sir.
potentially malignant lesion, you could have added. That's for the audience, just I am adding on it. And the question was asked just now that whether a scalpel or CO2 laser. You told ultimate goal is to eradicate or excise completely the leukoplakia. Is it not? But thing is that if you go through by CO2 laser, it is less this one invasive procedure, less trauma, less this one blood loss. A scalpel, sometime if come across a small vessels, there is a chance of blood bleeding, which we can control. So these are the only differences. Ultimate result is the same. As a surgeon, I'm talking.
Sir, we leave the choice to our surgeons, sir. We don't tell them what to
Yes.
do. Whatever they
No.
say, we just listen to them.
Just now the question was there, so I just wanted to add on it.
Thank you, sir.
Any other questions from the audience? Okay, then we end the session. I thank our speaker for an excellent and an insightful presentation. To conclude, managing oral leukoplakia and lichen planus requires a balance between the well-established clinical protocols and the thoughtful adaptation of new technologies, innovations ranging from molecular diagnostics, minimally invasive techniques, and a more precise, patient-focused future treatment options. So integrating these innovations with strong clinical judgment and regular follow-up will greatly enhance our patient outcomes. So I thank our speaker for an excellent and insightful presentation, and thank you for sharing your expertise, sir. Thank you.
Thank you, ma'am.
We now humbly request Dr. Sujata ma'am to felicitate the keynote speaker for this session, Dr. Srinivas K. Thank you, Dr. Srinivas, for a truly insightful, comprehensive, and thought-provoking lecture on oral potentially malignant disorders. Your presentation beautifully bridged clinical relevance with evidence-based insights, offering us a deeper understanding of early diagnosis, risk stratification, and contemporary approaches to management.
May I now request Dr. Sudarshan Sajjan, HOD, Oral and Maxillofacial Surgery from the College of KLE Institute of Dental Sciences to kindly felicitate Dr. Sujata ma'am. Thank you, ma'am, for chairing this session. and gentlemen, as we proceed to the next keynote lecture by Dr. Nadeem Ul Huda, it is my privilege to introduce our moderator for this session. It is an honor to welcome Dr. Rajnikant BR Sir to moderate the next keynote lecture by Dr. Nadeem Ul Huda. Dr. Rajnikant Sir is the head from the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Ramaya University of Applied Sciences. Dr. Rajnikant Sir brings with him nearly 17 years of experience in oral and maxillofacial surgery, supported by strong academic leadership and clinical excellence. His advanced training includes multi-system implantology, trauma life support, TMJ surgical management, and basic life support certified by the American Heart Association.
His research interests span tissue engineering, 3D scaffolds, platelet-derived growth factors, maxillofacial trauma, and cosmetic surgical innovations. Please join me in welcoming Dr. Rajnikant BR Sir, whose expertise and insights will guide this session with depth and clarity.
It's with a great honor and immense pleasure that I stand before you today to introduce our distinguished keynote speaker, Dr. Nadeem Ul Huda. He is a name which is synonymous with excellence, dedication, and leadership in the field of oral oncology. Dr. Nadeem Ul Huda began his academic journey of Bachelor of Dental Surgery from our prestigious VS Dental College and MDS from GDCRI, Bengaluru. From the very outset, his career has been guided by a profound sense of purpose. To Dr. Huda, the medicine has never been merely a profession. It has always been a calling, a lifelong mission dedicated to alleviating sufferings and confronting oral cancer with compassion, precision, and innovation. Currently, Dr. Nadeem serves as the head of the Department of Oral Oncology at esteemed Kidwai Memorial Institute of Oncology, Bengaluru, and he has over 25 years of experience. He is trained from one of the best cancer surgeons of India, that is Dr. M. Vijay Kumar, who is presently a Vice Chancellor of NAPA University, Mangalore. In this role, he has emerged as a committed clinician, a prolific researcher, and an inspiring teacher, making significant contributions to the patient care, academic advancements, and oncologic research. His clinical expertise and patient-centered approach have been profoundly impacted the lives of countless individuals battling for oral cancer. Dr. Nadeem's academic and research contributions have earned him a national and international recognition with numerous publications in leading peer-reviewed journals. His work has not only advanced scientific understanding, but also has influenced clinical practices in oral oncology well beyond institutional and national boundaries. A respected leader in professional and academic bodies, Dr. Nadeem is an executive committee member of Bangalore Oncology Group, a member of Board of Studies for Super Specialty Medical Programs, and former academic council member of Rajiv Gandhi University of Health Sciences. He has also served 2 terms as an EC member of Association of Oral and Maxillofacial Surgeons of India, reflecting the trust, the respect he commands within the professional community. An accomplished academician and mentor, Dr. Nadeem is a recognized trainer for maxillofacial postgraduate students, fellowship trainees in oral oncosurgery approved by RGHS. He also trains MCH surgical oncology postgraduates. His commitments to teaching and mentorship has shaped a generation of surgeons and oncologists who carry forward his values of excellence, ethics, and empathy. Through his leadership, mentorship, and unwavering advocacy for equitable and accessible cancer care, Dr. Nadeem Ul Huda continues to inspire students, colleagues, and a broader oncology fraternity. His works stand as a testament to the transformative powers of dedication, knowledge, and compassion in medicine. Ladies and gentlemen, it is really a true privilege to have such an eminent clinician, scientist, and educator among us today. Please join us in extending a warm and respectful welcome to our keynote speaker, Dr. Nadeem Ul Huda. Thank you, sir. Over to you.
Good morning, everybody. Thanks, Dr. Rajnikant sir, for this detailed introduction of my journey. I thank the management of Ramaya, the Honorable Vice Chancellor whom I met, Dr. Raina, the Registrar, Mr. Rao, and the dynamic Dean of Faculty of Dental Science of Ramaya, Dr. Kavita Prasad Madam, whom I met, I think around 1 month before in Government Dental College for a Dentist Day program. And that day, Madam has told, we will conduct a program of oral oncology in our institute. And that day has come today with her dedication and with her team. All of them has made it successful, and it's a well-attended program. I think more than 300 online, offline, 150 online registration. It's a big number for any program of scientific program. So today is a proud moment for me. I am addressing you all in front of my undergraduate teacher, Dr. Sharda Madam, who taught me DADH and oral pathology in VS Dental College. And my journey started from there, and I joined as a resident immediately after finishing. I did BDS. I didn't know what to do, that I did BDS. My father told you do BDS. I wanted to do civil service, but somehow I could not do. Then immediately finishing our BDS, my BDS, I joined Kidwai Memorial Institute of Oncology under Dr. Vijay Kumar, who is my teacher, mentor, who was heading the department of oral oncology that time. And with his scolding, guidance, and constant support, today I am in front of you. I learned surgery from him. I have learned talking from him. I have learned science from him. And every day, almost every day, I talk to him like a small kid to improve myself. So with all this small thing, introduction of mine and in general, I will talk about oral cancer, which will not take much of time. I am not going to bore all of you. Just small, already Dr. Srinivas has given a brief about the leukoplakia and lichen planus. Actually, I give talk all over the country. My aim of this talk is to either early detection of the oral cancer. First is the prevention of oral cancer. If you can prevent, or you detect early. So the aim of this talk is to all of you are going to be clinician after coming out of the college, and you are going to practice in a different part of the country. So it's your duty, bound duty, as your Honorable Vice Chancellor also told. So society has given us a position, so we have to give back to the society. So if you are, even though you are practicing in a different part of the country, in a different field of the dentistry, but you can prevent oral cancer and you can detect early oral cancer. This is just a small introduction about oral cancer. Oral cancer is the 6th most common type of cancer in India, and the burden is around 2,74,000 new cases and 52,000 deaths. Why it's happening? That's all because of late detection, late treatment, and we land into this. So our aim is to reduce the burden as much as possible, to create awareness among you dental surgeons. You have a pivotal role in detection of oral cancer, controlling of oral cancer. If you detect early and send it to me, I will treat. If you send it to me in the stage 1 and 2, I will cure. If you send it to me in the stage 3 and 4, I will treat and wait for the result which we had to see. So next, this one, my topic actually is oral cancer and its management. So as you know, all of you know, oral cancer is because of tobacco and tobacco related product. There are various forms of tobacco is used in India in a different part of the country. Every state they will use in a different form. So this is tobacco is in 2 forms. It's called a smoking and a smokeless tobacco, alcohol and betel-nut. So sometimes people take tobacco along with the alcohol, their synergism happens. So these are the risk factors of oral cancer: environmental, epigenetic, genetic, and ill-fitting denture. Again, your role will come here. Ill-fitting denture. So if you are a dental surgeon, and if patient comes to you, and if you thoroughly examine the oral cavity, and if you find an ill-fitting denture, and the patient has got some habit also along with the ill-fitting denture, you should be careful. Immediately you should act, and if below the denture on the alveolar region, if you see any small lesion or ulcer, immediately you have to act. Either if you are an oral surgeon, you can do the biopsy, or you send it to a particular expert who can do the biopsy, or a center where biopsy can be done. It may be malignant, or it may not be malignant, or it may be in a transformation stage to be malignant. See, this is I think madam will talk in oral pathology next. Madam topic is there, Radhika madam, about this. This is also, I think it's for all theoretical purpose. So what is oral cancer? Oral cancer arising from any part of the oral cavity, and if ulcer persists more than 3 weeks. Here I will again add on one more thing. You as a dental surgeon, I think your Honorable Vice Chancellor also told that you just not examine the only oral, what is the chief complaint. As a dental surgeon, patient will come with the pain, bleeding. You should not only see the pain and why the cause of bleeding is there. You should thoroughly examine the oral cavity. If you, even Kavita madam add in the welcome address, if you thoroughly examine the oral cavity, if you find anything, any ulcer, any lesion, and if you ask the patient, your patient, if there any habit, then you should suspect something, and if you can diagnose at that level, you can save one life. This is about oral cavity subside anatomy. As you all know, upper lip, it starts from hard palate, soft palate, upper gingiva, retromalar trigon, buccal mucosa, tongue, floor of the mouth, and lower gingiva sulcus, and lower lip. Here the tongue is the most notorious subside in the oral cavity. As a surgeon, we go give all the treatment for the tongue, and it will come with the recurrence, even in 6 months also, 1 year also. I do surgery, I send it for my radiation colleague for giving radiation, and they send it to their medical onco and add chemotherapy also. It's called concurrent CT-RT. In spite of all we do, we see the recurrence very early, especially in younger patient. That's why I tell the dictum, younger the patient, aggressive the disease. I have seen recurrence from the best of the best hand also, and from my hand also. I've seen recurrence from my teacher Vijay Kumar hand also, and I'm seeing recurrence from my hand also. Here, the biology of the disease matters. We don't have the control over the biology of the disease. We can do surgery, we can give all the treatment. In cancer, there is one part which is called biology of the disease. We don't have a control over the biology of the disease. If the biology of the disease behaves abnormal, it's very difficult to control cancer. This is depth of invasion, DOI is very important. This madam will talk. I think in pathology, it is also very important. This we see in our post-op HPR report. On the basis of depth of invasion, I have made it a protocol. Whichever surgery I do, and if post-op HPR report comes, I send it to my radiation oncologist colleague. They will decide whether adjuvant therapy has to be given or not. But these are the some of the pathological parameter which they consider to add adjuvant treatment, radiotherapy, or concurrent CT-RT or not. That I think Radhika Vavle madam will explain in detail. These are the important things: exophytic and invasive. Exophytic growth you can get a good margin in exophytic growth. But when the lesion is invasive lesion, it's very difficult to get a good margin. So sometimes actually we stick to the 1 centimeter margin. But as a surgeon, if you are seeing the disease is aggressive, and if you have a chance, a good reconstruction, you cannot stick to 1 centimeter margin. You can go more than 1 centimeter margin, give a good margin, and do a whatever reconstruction available. If you are a reconstructive surgeon, you do the reconstruction, or you have a reconstructive team, they will do the reconstruction. You do resection, hand over to them, they will do the reconstruction. But don't compromise on the margin. And in the exophytic growth, you will get the good margin. But when it is invasive or infiltrative tumor, then the margin is getting is a challenge. This is about the TNM staging, which all of you know if you are a postgraduate student. I think all of you must know, because when you are taking the case history, you have to write at the provisional diagnosis and TNM staging. So there are 2 times we assess as a TNM staging. One is during the provisional diagnosis time, we give one clinical TNM staging, and second, when madam will give me report, that time post-op HPR, she will write the TNM staging of the what is the pathological specimen which we send. This is all called AJCC classification of TNM staging. This is very important oral cancer diagnosis for all of you, because you are a clinician. If a patient comes to you, how will you diagnose? You cannot send the patient for everything, for PET scanning or whatever. You have to have a thorough this one history or taking of the patient. As all of you are youngster, please don't miss anything during history taking, like how the lesion is, if anything lesion is there, since how long it is there, how it came. Then second, you should ask whether he is associated with the pain or any other thing. Third, you have to ask, which is very important in oral cancer, whether there is a habit or not, then whether there is a sharp tooth or not, or ill-fitting denture is there or not. Then you have to go through the medical history of the patient. Medical history is important because it will help you in the treatment planning. If I am a surgeon, if your patient is fit, then only you can do the surgery. If a patient is having medical history, then you have to take all these things, underlying causes into the consideration, whether the patient is hypertensive, diabetic, or any cardiac event or renal problem, then you have to treat them, take your anesthetist consent and fitness, and then you can take the patient for the surgery. So medical history is also important. Family history, as there in the oral cancer, family history, nothing much I have seen in my experience of 25 years, but as a protocol, you have to take family history. Then now you come to the examination. Examination is very important, and it is called intraoral and extraoral examination. Intraoral examination means, as I told you a few slides back, which was telling about the oral cavity subside. So intraoral examination, you have to do thorough examination of the intraoral cavity and see where the patient is telling what is the chief complaint. If it's telling a lesion in the buccal mucosa, but that doesn't mean only you see the buccal mucosa and leave other parts. You have to see, sometimes two primary will be there, some buccal mucosa, another will be below the tongue, it's called floor of the mouth, or some other place palate also may be there. It's rare, but it's so thorough. You have to do thorough intraoral examination. Now it comes to the extraoral examination. When you do the extraoral examination, you have to see the face, if there is any swelling or anything is there. Then you have to go behind the patient and thoroughly you have to examine the neck, turn the neck towards your side, and then examination of neck will tell you whether there is any swelling is there in the neck or the nodal status. Some of the if the node is obvious, then only you can palpate. Some of the node you may not palpate. For that, we will take the radiological evaluation. That is okay. So after examining all these things, then you will come to the conclusion of your provisional diagnosis. You give a provisional diagnosis, and then you have to give one TNM staging of that time. That is called pre-treatment, which we take into consideration. Post-treatment, madam will give, when I will operate and give it to the specimen, and she will write the type, stage, and everything. Okay. So that is the art. Now, after this, you have to come for examination. What all investigation you have to do? You cannot do whatever you want to do. Our oral cancer patients come from the low socio-economic status. So you should do minimum what is required. What is not required, you should not do. So for that, you should have a thorough blood picture where CBC, LFT, RFT, which will give you a picture of renal function test, liver function test, and then H test called HIV, HbSAg, SCV and SCV, where you had to take precaution if the patient is biohazardous, what all precaution has been to be taken inside the OT during your any procedure when you are doing. Then you have to come to the radiological evaluation. Radiological evaluation nowadays, it has become fashion. If you go to any cancer surgeon, they will write PET scan. For every patient for oral cancer, PET scan is not required. I also write PET scan when it is required. PET scan is required when recurrence comes, when we write PET scan to evaluate the distant metastasis. But in a normal, our oral cancer patient, if it's buccal mucosa and we want to know about the bony involvement, then we can give a CT scan from the face, neck, and we include the thorax to analyze whether the lung is involved or not. Most common distant metastasis, that's all, enough. And if a tongue and floor of the mouth and swelling is there, soft tissue evaluation, we give only MRI. That's all. Now comes to the PET scan. I am not disagree with the PET scan or against PET scan. PET scan is required when the patient comes with the recurrence, and that time you have to assess the patient for the distant metastasis, and that time you can give the PET scan, and after PET scan you can do the treatment planning. We use sometimes ultrasound guided FNAC. Sometimes we had to do FNAC for a patient. At that time, ultrasound also we use. And as I told you, some of the node you may not be able to examine during palpation. That time also to assess the node, we can go for the ultrasound guided to evaluate the node. This is about the biopsy, which is very important. You are if majority of them, if you are clinician, oral surgeon, you have to do the biopsy. When will you do the biopsy? If the lesion is there, then if a suspected lesion is there, and you feel that a lesion may turn out to be malignant, that time you have to do the biopsy. So biopsy, and then again I will tell you in details about biopsy later. What I will tell you, what all other things you can do, biopsy and FNAC. When will you do biopsy and when will you do FNAC? If there is a lesion, frank lesion is there, and you are suspecting the lesion to be malignant, you can do the biopsy. FNAC, if there is an inaccessible area, if a trismus is present where you cannot access to do the biopsy, if there is a swelling in the near the parotid, or swelling in the face, swelling in the neck and the closed area, then you can do the FNAC. Okay. Now I'll come to the biopsy. Biopsy is of three types generally we do. First is incisional biopsy, which we do regular in our clinical practice, where in that incisional biopsy, what you do? You include the affected area with the normal area and send it for your pathologist colleague, and they will give report within 3 to 5 days. On the basis of that report, we do treatment planning. That is called incisional biopsy. Sometimes lesion is suspected, and in spite of doing continuous biopsy, we are doing incisional biopsy 2-3 times, and the report is not coming conclusive. That time we do the excisional biopsy. We do complete excision of the lesion and send it to our pathologist colleague, and they will give report. Sometimes it comes positive also and negative also. If we see that highly suspected benign lesion, generally I see majority of this type of lesion in my cancer, my hospital, and that time what I do, I post the patient under GA and do the excision biopsy, or it's called wide excision, and send the specimen to our pathologist colleague. We have a wonderful pathological department, one of the best in the country, and our pathologist colleague will do frozen section, and they will immediately give. So what happens if they give positive, immediately I will address the neck. If N0 neck, I will go for SHND. If N0 neck in tongue, I will go for 1, 2, 3, 4 extended SHND. If N plus neck, I will come in the details, modified neck dissection. So what will happen in the one sitting itself, patient will get the treatment, and he will not be subjected twice for surgery. If we send just like that, excise and send, report will come after 5 days, and then again, if it comes positive, we have to address the neck, and that time again we have to prepare the patient for GA and take it to the OT and do. So if you have a good pathological backup, you can excise, send it to your pathology colleague, they will do the FS, immediately you can address the neck, and the one sitting you can do the proper treatment. This is about factors that influence the choice of initial treatment. As I told you, site of the primary tumor, location in the oral cavity, size, T stage, proximity to the bone, whether bone to be removed or not, that I told you CT scan will give the idea, and various type of, this one is there, mandibular resection, which I will come in the later. Status of the cervical lymph node, why just now I told N0 neck, what we will do, what neck dissection will do, N plus neck, what neck dissection will do. The idea of status of cervical lymph node will help you to plan your neck dissection. Histology, type, grade and depth of invasion, and previous treatment, if it is given to the patient, how to go. Suppose the patient is irradiated, you have to be careful. On table there will be a bleeding, other things will be there. This is the patient factor. Age is important factor. Age has to be considered. General medical condition, as I told you, if the patient is having underlying medical cause, you have to address that cause, and then only you can send it to your anesthetic colleague for pre-anesthetic checkup, and if they give fitness, then only you can do surgery. That's the third is occupation. I think acceptance and compliance is a very important. Treatment acceptance for the patient and patient relative. How you convince the patient about the treatment planning, result, and the complications. It's all important. That's called counseling. Counseling is also one of the major part of our oral cancer treatment. Oral cancer surgeon, you cannot only a surgeon, you have to be a doctor, you have to be a philosopher, you have to be a relative of the patient. You should not leave the hand of the patient till the end, but subsequently you should inform the patient relative about the disease, about the progression of the disease, about the result, about the recurrence, and about the palliation. So physician factor, surgical skill is important. If you are not well trained in oncology, please don't do surgery. You cannot do the surgery and blame it to cancer, that it is because of cancer it has come. Until you are well trained, you are well trained, you are going to operate, then only you should operate. Radiotherapy skill, that will be given it to, because it has to be done in a setup where all the facilities are available. After doing surgery, you send the patient to your radiotherapy colleague, and they will take a decision whether the radiotherapy has to be given or not. Chemotherapy, same. Your medical oncologist should be there. The team of medical oncology, they will decide whether the chemotherapy has to be given or not. Dental and prosthetic, this one, services is also important. That pre-op dental, what all dental prophylaxis has to be given, and post-op rehabilitation, which is the role of dental surgeon and prosthodontist, is very important. And that is the rehabilitation series. Rehabilitation also here, again prosthodontist plus speech therapy, various physiotherapies, various other branches which we take support. And the supporting care, support services, it's called palliative. When patient is in last stage, we need to give support. As I told you, we have to be a philosopher, we have to be a guide, we have to be a relative of the patient. In cancer, you have to have a holistic approach of the treatment. You should have passion, compassion, and empathy to treat cancer patient. If you have this, then only you choose cancer as a carrier, otherwise not. This is the management of oral cancer. Management of oral cancer is 4R is important. That is called resection, reconstruction, rehabilitation, and early detection of recurrence. Resection, I as a surgeon will do resection, reconstruction. Either if I am trained in the reconstruction, I will do the reconstruction, or my plastic surgeon colleague or the team of plastic surgeon will do the reconstruction. Third is rehabilitation, as I told you, prosthodontic colleague, and they will, speech therapy, they will do rehabilitation, early detection of a recurrence, which is very important. If a patient is come to you with a recurrence in early, as I told you, tongue is the most aggressive disease in the oral cavity, and if the tongue comes with the recurrence, again if recurrent come, if you can do the surgery, first and foremost treatment in the cancer is surgery, you do the surgery. So if it is very important, early detection of recurrence, then how you will catch the early detection of recurrence? If your follow-up is proper. If your follow-up is not proper, you will not be able to do the early detection of recurrence. So we have made a protocol. For first 1 year, I call a patient for every month. Second year, I call the patient for every 3 months. Third year, I call the patient for every 6 months. During the follow-up, if me and my team member, if see any suspicious lesion, immediately we intervene, and what best can we do, we can do. These are the treatment modalities. In cancer, it's called combined modalities of the treatment. One treatment is not the only treatment, where first is surgery, second is radiotherapy, third is chemotherapy, and fourth is combined modality. So surgery is the first foremost treatment. As a surgeon, I'll do the surgery. But sometimes if the patient, the tumor is unresectable, that time we go for a NACT. It's called new adjuvant chemotherapy, that time, that the role of neoadjuvant chemotherapy is, it makes unresectable tumor to the resectable tumor. We refer this case to the medical onco colleague, and then they give the chemotherapy drugs, and subsequently we will keep analyzing, and generally after 3 cycles we will assess the patient. If patient is for resectable tumor, I as a surgeon will resect. There is a paper about this NSCT, role of NSCT in head and neck region. My good friend Dr. Kumar Prabhas, who is heading the Department of Medical Oncology in Tata Memorial, Mumbai, and he is also the director of Tata Muzaffarpur. Recently I met, he has done multiple trials on head and neck cancer. So second is radiotherapy. Radiotherapy, when surgeon do the surgery, then I will send it to radiotherapy colleague. After receiving the post-op HPR report, on the basis of post-op HPR report, there are various parameters is there. So radiotherapist will consider that parameter and advise for the radiotherapy. If he feels like to add in chemo, it is called chemo concurrent radio, RTCT, it's called radiotherapy chemotherapy concurrent. There one drug they use cisplatin, and this is called radiosensitizer. Then our radiation colleague will send it to medical oncologists, and they will add the chemotherapeutic agent that is called concurrent CT RT. Now again, sometimes we give palliative RT, not we, I refer, my domain is surgery. Whereas you had cancer, you have to have involved all 3 of you. You cannot, not 3, one more, pathologist also. And then you can take it. Proper treatment planning is important. You cannot do the surgery and go back and do correction. Before doing treatment planning, you can think 10 times. After giving treatment, you cannot go back and correct the treatment. So please do a thorough treatment planning and then start the cancer treatment. Don't do half-heartedly treatment and blame the cancer. Cancer was bad, that's why you are suffering. This is the 2 type of treatment, as I told you, curative and in palliative. Curative, T1, T2 lesion. If you early disease, stage 1, stage 2, if you send it to me, I do surgery, and I've been seeing patients coming after 5 years also. But 3 and 4, still we do surgery, but we give all the treatment, adjuvant treatment also, wait for the result. Sometimes patient comes in the 1 year also, recurrence, 6 months also, as I told you in tongue, we have seen best of the best hand. So this is best is the curative treatment. That's why this program talk is very, I made my slide very simple. If I wanted, I could have talked very high-fi, whatever the researchers paper and all those things. That was not needed here. See, now, if it is your role is very important, your role is pivotal as a dental surgeon, whether you are doing prosthodontics, endodontics, orthodontics, oral surgery, you are going to do the clinical practice. When you are going to do the clinical practice, and if you are in clinics, if you see a patient, and if you identify a lesion at an earlier stage, and if you ask about the habit, and you send it to a right place or a right center, you are saving a life. Life saving is not that easy. Your role is very important. As your Honorable Vice Chancellor has told, every profession has got significance. We have to make the significant. When I joined in the Kidwai, I never know what I will become. Today I am standing on the podium and addressing you. I never thought that I will become a cancer surgeon. But God has gifted me an opportunity. I am the only maxillofacial surgeon in the country who is heading the Department of Oral Oncology in a regional cancer center of India. It's because of blessings of Almighty, my parents and my patients. That's all. This is about the curative treatment, T1, T2, and that I told you, palliative, T3, T4, and sometimes we give palliative treatment. Single modality treatment is stage 1 and 2, where surgery is the only one choice, and the stage 3 multimodality treatment, surgery, radio, chemo, everything we give. This is about unresectable tumor, T4A, T4B, which is told, if it is going to ITF, we don't resect the tumor. This is about mucosal margin is very important in any cancer surgery. If you give a good margin, then only can have a good result. As madam knows, surgeon will send it to her, and then she will see the margin. If the margin is nearby, margin is close. Even Sharda madam is here. She's a very good histopathology expert. She taught me oral pathology, and that time I didn't know whether I will become this oral surgeon or cancer surgeon or not. This is about the surgery in block resection with 3-dimensional 1 centimeter margin is theory. But if you think If you think you should give always a wider margin, especially in the tongue. There's a paper of Tata Memorial also. You should give a wider and wider margin. You should not confine to your theoretical 1 centimeter margin. And as a pathologist, both Sarda madam and Radhika madam see, sometimes the margins shrink. Pathological margin will be different, surgical margin will be different. If I give surgical margin of 1 centimeter, she will give our pathological report of 0.7 centimeter. This is about a surgical approach, tumor size, tumor size. So according to the size of the tumor, you have to plan tumor site, where it is situated, your treatment planning according to that, tumor location, proximity to maxilla or mandible, whether to remove maxilla or means partial maxillectomy or mandible. Mandible, various type of mandibulectomy is there, marginal mandibulectomy, segmental mandibulectomy, hemimandibulectomy. It all depends on how much is involved. Need for neck dissection, types of neck dissections are there. SOND is called extended SOND, MND and RND. MND, various types are there, type 1, type 2, type 3. And need of reconstructive surgery, if whether the local flap is required, free flap is required, regional flap is required, is decided by the surgeon and his team. This is about investigation, which I have already talked. This is a PET CT, I have already told. Pre-oral approach. This is called pre-oral approach. If a small lesion is there, here we have excised the lesion of the tongue, a small excision. If the reconstruction is not required, primary closure you can do and come out. This is about the raw area, which I am seeing. Transcervical approach, this is not common nowadays. Earlier it was done. Lower cheek flap, which we are doing regularly in Kidwai, because to remove the mandible or the part of the mandible, and with the neck dissection we do hemimandibulectomy or segmental mandibulectomy, and do one. Generally we do regular. Yesterday only I did 2 PMMC flap, which we do regularly in our center. This is upper cheek flap. If you have to do partial maxillectomy or alveolectomy, this approach is, you can use this approach. Incisor designed for mandibulectomy, its incision is very important. If you do proper incision, if you don't do proper incision, there is a chance of necrosis of the flap is there. Tumor invasion of the mandible. According to the tumor invasion of the mandible, I told, if the tumor is just abetting, it's called marginal mandibulectomy. You have to remove the rim of the tumor, rim of the mandible. If the tumor is sitting on the segment, then you have to do segmental mandibulectomy. And if it is mandible is involved, you have to do hemimandibulectomy. This process section I have already talked. Neck management, I told you there are, we SOHND, if there is a N0 neck in the subside buccal mucosa, GBS, if it is there, we do supra-oma head neck dissection, where we remove level 1, 2, 3, and this one, all structure will be preserved. If there is a tongue or N0 neck, then we go up to level 4. Level 1, 1A, 1B, 2A, 2B, 3 and 4, preserving all the structure. If there is an N plus neck, then the surgeon decision on the table, type 1, type 2, type 3, MND is there, where one structure is preserved, 2 structures, sometimes nerves, sometimes vein, and sometimes all 3 we preserve. So it all depends on the surgeon. On table, surgeon has to see how to go about, because it depends on how much nodes are present. According to that, if the node is stuck to the IJV, we cannot spare the IJV and do the surgery. You have to remove the IJV. If not, nodes is present in the course of the nerve, the spinal accessory, you have to remove the nerve. Then, so these are the R&D, where all 3 structures we remove. This is all theory. I have told you basics. They are only simple basic about neck dissection, supra-omad neck dissection, extended supra-omad neck dissection, MA modified neck dissection, type 1, type 2, type 3, 1 structure saving 1, type 2 structure 2, 3 structure. That's all. The R&D radical neck dissection. That's all you can understand. See, this is about reconstruction. As I told, if I am also if I have learned reconstruction, I will do the reconstruction. Or if I have a team of reconstruction, I will do resection and hand over the this one to the our reconstructive team. They will plan and decide. This is healing. I told you, if a small tongue lesion is there, we will excise and primary closure, healing by second intention, a split thickness skin graft, but generally we don't use now. This is a nasolabial flap, which is very common flap I do in my place. If there is a small lesion in the angle, we will excise and do one nasolabial flap, patient will do very well. This forehead flap, earlier we used to do, nowadays they are not doing because of the cosmetic reason, but sometimes if you don't have any choice, you have to do the forehead flap. This pectoris major flap is a very, very common flap which I am doing every day in Kidwai, and this is one of the best flap which you can do this flap and come out. If you don't have an option to do free flap has many positive and negative point. If the patient is low socioeconomic status, the cost is very high. Even a government setup also we do, but it all depends on proper training, proper setup, so many factors, underlying cause, patient's healthy, patient's fitness. Anterolateral thigh flap, it is also free flap. It's all if you have a reconstructive, which I've already told, radiotherapy and chemotherapy is called adjuvant therapy. This surgical margin, clear margin, as I was talking, Sarda madam and Radhika madam is here. I will excise and send it to her. If the margin shrink, it may be, what is my margin? It's called surgical margin. What is her margin? It's a pathological margin. But if you have a chance, you give a wider margin. And if you have a reconstruction option, it's better to give a wider margin so that the recurrence chance will be very less. This is about margin shrinkage, which I have already told. This follow-up also I have already talked. Palliation, we have a wonderful palliative department. If the last we send it to patient to palliative, but here also, as I am telling, you should be not only a cancer surgeon, cancer doctor, you should be a philosopher, you should be a relative of the patient, and but you have to keep informing the relative about the disease, about the recurrence, about the result, about the chances of recurrence. This is a life touched by cancer, is not a life destroyed by cancer. The future belongs to consistent, not the talented, not the lucky, but the one who shows up even when it is hard. Motivation is what gets you started. Habit is what keeps you going. My teacher used to tell you should have 3 P, patience, perseverance, and prayer to work in cancer, and 3 D, dedication, devotion, and determination. It will take you a big height in any profession. Thank you.
Thank you, sir. It was a very precise presentation which catered to undergraduates, postgraduates, and the clinicians and the academicians. Some of the key points what sir has told, I would like to just readdress them. What sir and earlier madam also told in the initial talks, that is like importance of dentists. So we are the first people to see a person's oral cavity, and our job is not to just look at the teeth. See, the teeth are there because of the surrounding structures. The foundation is there. So you need to look at the detailed examination. I am sure that all of us have a very brief, detailed examination format for the both hard tissues and soft tissues. If you can just go through a clear and thorough examination, you can make out many disorders or diseases which are actually unnoticed, which are accidental in finding. Then, sir, stress the importance of depth of invasion. See, nowadays, it's not about how big the tumor is, how deeply it is infiltrating within the tissues. That has become a more concern nowadays than the size of the tumor per se. And even our AJCC recent classification has given a much more importance to the depth of invasion. And today, if you look at the conference posters, many of them are addressing this depth of invasion of the tumor. And one more important thing what sir mentioned is, today we have a good reconstruction options. Not those days where we have to worry about can I access a little more, what deformity it causes. No, there are good reconstructive options, and we have to be happy that we are a part of that reconstruction option. See, it is not just that the bone and the soft tissues you just place in the area where it is deficient. Who will give the functional occlusion? Who will give the functional teeth? Who will restore the appearance? Who will restore the aesthetics? It's the dental surgeons. So our role primarily comes there. So I request many of you, if you are having interest in restoration of the oral tissues, post-surgery, post-resection, so it will be a very great value to our profession. Then sir mentions about the empathy. It's not that the patient comes to you with happiness. He has a concern, he has some of his problems. So when he comes, your first visit your bondage occurs, and then you had to do a subsequent treatment. And trust me, if I go back to my postgraduate days, a hospital teaches more life lessons. You will know what a real life when the patient is admitted, how the patient's attenders take care, what are his concerns, how he is feeling in the last days. So that will actually change your perception about the life. Then, and finally, sir told about the group work. See, it is not just one person's work. See, there has to be radiologists, oral medicine people, there are people who are doing surgery, there are people who are doing reporting, there are people who are doing rehabilitation, and there are psychologists who can address the concerns. See, not just the oral cancers, even the other cancers, no? If anybody comes to know that today his life is okay, and suddenly if somebody tells him you have a cancer which is not curable or which is having a very bad prognosis, imagine the impact that the patient has. So these are the things which we need to address. Thank you, sir. Thank you for covering such a elaborate topic in a simple way. Thank you very much.
Thanks. Once again, I thanks the management, and the Honorable Vice Chancellor Registrar, especially the Dean, Dr. Kavita Prasad Madam, who took the initiative 1.5 months back, and she made it today with her dynamic team. I have been seeing everybody is involved. She had taken everybody into consideration, confidence, and made it today. Thank you very much.
We now humbly request Dr. Rajnikant sir to felicitate our keynote speaker, Dr. Nadimul Huda sir.
Thank you, Dr. Nadimul Huda, sir, for an engaging, insightful and thought-provoking lecture on oral cancer and its comprehensive management. The manner in which you highlighted evidence-based treatment protocols, advances in surgical and oncologic management, and the role of timely referral was both enlightening and clinically relevant.
So we have few questions from the audience.
Please ask whatever you want, you can ask. Because young mind are there. You whatever it comes in your mind, you ask about oral cancer. I am here to answer.
Good afternoon, sir.
Good afternoon.
So you mentioned that we will give GA to the patient and then we send the excised lesion to the pathologist without incisional biopsy, sir. So is there any chances that this could turn out to be non-malignant, or and how frequently should we, like, do we avoid incisional biopsy and directly go for excisions?
No, if first we attempt incisional biopsy, but what happens in our clinical practice, 2 times you do biopsy, even 3rd time, the biopsy report comes inconclusive. Clinical, it's called clinically pathological evaluation. Clinically it looks positive, pathologically it looks negative. Then you have to do something. Na? So what you will do is better to do excisional biopsy. So for excisional biopsy, it's better to do under GA, where you can take it to your major OT, do an excisional biopsy. As I mentioned, send it to your pathologist colleague. If you have a pathology, you will definitely have a pathology setup when you are working in a big setup. Send it to your pathologist colleague. Send it for frozen. In the frozen, you will come to know whether it is benign or malignant. If it is benign, excise it completely, close it, reverse the patient, shift it to the ICU, patient will be all right. If it comes malignant, then next what you have to do, you have to address the neck. In cancer, even if it's N0 neck, you cannot leave the patient. So now you have to plan for the neck dissection. So what advantage of it, in one sitting itself, you are doing the job. Suppose you send it like casually to that and you don't ask for frozen section, then close the patient, send it. After 1 week, the report will come. Again, you have to subject it for the surgery. That time, patient or patient relative may agree or may not agree for surgery, number 1. Number 2, the cost will be, if it is BPL, it is all scheme free, but if it is cost, that cost will be there, number 2. Number 3, psychological trauma. Number 4, again subject to the surgery. So all this, why do all this thing? When you have a facility and when you are a skilled surgeon, when you are going to do, when you know how to do neck dissection, then why will you wait?
Good afternoon, sir. Thank you for your insightful presentation, sir. So I have a question, sir.
Yeah.
What is the percentage of chances for having a skip metastasis, sir? And in related to oral cancer,
It's
wha-
one,
which is
very percentage. There are various publication. It's come in the. You can go through the article. Okay. As a clinician, as a surgeon, escape metastasis chance is very high in carcinoma tongue. That's why I told you, if any other lesion is there, subside, where we excise the lesion, and when it comes to the neck dissection, we only do supraomohyoid neck dissection, where we are addressing level 1A, 1B, 2 and 3. When it comes to tongue, even if it is N0 neck, we address the level 4. Why? Because of that escape metastasis.
Thank you, sir.
Sir, very good afternoon, sir.
Good afternoon.
Sir, you had mentioned ulcer more than 3 weeks is ulcer.
Yes.
Cancer.
Yes, not cancer, suspicion.
Okay, sir.
You cannot say cancer. You should suspect, number 1. Then you have to ask about the habit. If the patient is having habit of chewing tobacco or smoking, then immediately you should be alert. Any ulcer cannot be cancer. But ulcer, if you see persistent ulcer, number 1, if the patient is having habit. Number 2, if it is a sharp tooth. Number 3, if it is an ill-fitting denture, then you suspect it as a cancer. And what you have to do, you have to send it to your oral surgery colleague, or you call them to your clinic, get done one biopsy. That biopsy will tell whether it's a benign lesion or malignant lesion.
Thank you, sir.
Good afternoon, sir.
Very good afternoon.
You have mentioned in the treatment that radiotherapy and chemotherapy
Yeah.
will be done for extra large lesion. Then later it is advised for surgery. My question is.
No, what your question only is not, I have not understood. Please make it clear.
Sir, for extra large lesion, initially.
Which extra?
Large lesion.
Large. It's I talked about unresectable tumor. You can tell in layman word. You can tell extra large lesion.
My question is, cancer treatment, is it done surgically removed initially and simultaneously started with the radiotherapy and chemotherapy?
Yeah, that's what I told. Na? I have mentioned clearly. When there is unresectable tumor, then we will send it to the chemotherapy, radiotherapy, not chemotherapy. Why chemotherapy? That is called neoadjuvant chemotherapy, where our chemotherapy colleague will give the patient to the chemotherapy, and it's called in scientific term, downsize the tumor. Tumor size will reduce. Then you will, again, first you have to do one pre-chemo assessment with your CT scan. What was the size of the tumor, or MRI, what was the size? Again, after generally, I have seen 3 cycles they give our medical oncologist colleague. After 3 cycles, they refer it to us back. That time we do again assessment, then we will send it for CT scan. Then we will see whether the size has been reduced. So if it is called in other term as a surgeon, unresectable to resectable. If it is resectable, I'll do the surgery. Okay. If it is not resectable, then we'll discuss, think about giving. It is not curative RT, palliative RT, or that is, again I told you, cancer is a multimodality treatment. We'll take it, discuss it, and then we'll decide it. About radiotherapy you asked. Radiotherapy we give after surgery. We do surgery, and whatever patient is my protocol. Recently, FHNO, I had a discussion with one very big doctors. I told, I have made a protocol in Kidwai, whichever patient I do surgery, once the post-op HPR report comes, with that report, I send all my patients for radiotherapy. Radiotherapists are the one who will decide whether to give radiotherapy, number 1, or to keep the patient on follow-up. They will decide, and documentation also is needed. Suppose tomorrow that patients come with the recurrence, and if you are not given radiotherapy, then what will you answer? You have to take care of a medical legal also. Anything else? Thank you.
Good afternoon, sir.
Good afternoon, ma'am.
Yeah, Thank you very much for
Because of
accepting
you,
our
I am here.
invitation. Yes,
Your
sir.
persuasion from GDC and today in Ramaya.
Yeah, thank you so much, sir, for accepting our invitation. So, I just wanted to ask you, like, in your experience, what pre-operative investigations do you advise other than our regular clinical examination
See, madam,
and radiology in order to have a good idea about the tumor behavior and for you to make a surgical plan for your patient?
Madam, nothing extra we do. We need one biopsy or FNAC report because until biopsy positive is there or FNAC positive, we cannot intervene, number one. Number two, radiological evaluation to plan the size of the tumor as well as the bone is involved or not, or in a soft tissue, tongue and floor of the mouth or neck swelling, we do MRI, this one, to assess. Sometimes this some medical history if it is there, thyroid. So that time you have to take all the thyroid profile, you have to get it done. And this one, sometime there will be a, we see regularly with the oral cavity CA, you will get one midline swelling. In thyroid also will be there. So that time you have to have very proper planning. So oral surgery, oral cancer we will address. The thyroid either we will ask our head and neck colleague or surgical onco colleague. They will come with a team. We do that surgery.
So, do you rely on any markers like either the blood markers?
No, markers we don't do before. Pre-op we don't do. Post-op sometimes which is rare, that sarcoma and all are rare in the oral cavity, and that spindle cell carcinoma is there. That is also, that time our pathology, we have a wonderful pathology team, wonderful department, one of the best in the India, and there they decide whether to do IHC and then they will do the marker. In generally in oral malignancy, it's less with my experience of 25 years.
Thank you, sir.
Thank you, ma'am.
Thank you.
Thank you, sir, for taking all the questions. May we now request Dr. Kavita Prasad, ma'am, to kindly felicitate our moderator for this session, Dr. Rajnikant, sir. Thank you, ma'am. Thank you, sir, for expertly moderating this session. Now we move on to the last session of the day. We are truly honored to welcome Dr. Sharda P. ma'am, our moderator for the final keynote lecture by Dr. Radhika M. Bable ma'am. Dr. Sharda ma'am is a distinguished oral and maxillofacial pathologist with over 31 years of experience in academics, research, and histopathology. Ma'am has delivered and presented scholarly work at numerous national and international platforms, including oration lectures, slide seminars, guest lectures, and global scientific forums. With numerous publications in national and international journals, she has also contributed 3 chapters to the multiple editions of Orban's Oral Histology and Embryology textbook.
She has held key academic responsibilities as a member of Board of Postgraduate and PhD Studies, is a recognized PhD guide, has served as Vice President and President of the Indian Association of Oral and Maxillofacial Pathology, and is a Fellow of the National Foundation of Clinical Forensic Medicine. I welcome Dr. Sharada ma'am to moderate this session and introduce our esteemed speaker for the final keynote lecture, Dr. Radhika ma'am.
A very good morning to all the faculty members, Dr. Kavita, and all my colleagues, students, and dear friends. It's a great privilege and honor to introduce Dr. Radhika, who has been my friend for the last 25 years. We have spent beautiful moments together in many, many conferences, which we can never forget, and they are the best memories we have in our academic career. And whatever has been spoken about me, I think it is not is now, it is was. I was a PhD guide, I was a PG teacher, now I am not into academics at all since the last 2 years. So Dr. Radhika, an eminent academician, diagnostician, accomplished researcher, inspiring mentor, and a dedicated clinician. She has held several prestigious academic and professional positions in her career. She has served as the honorary editor of the Journal of Oral and Maxillofacial Pathology, a PubMed index journal run by our association, the Indian Association of Oral and Maxillofacial Pathologists. She's also been an EC member of our association, that is Indian Association of Oral and Maxillofacial Pathology, for 3 consecutive years. She has chaired the Inroad launched by our association in 2019, which is basically aims at structured data collection on oral diseases all over the country. She is a recognized postgraduate and PhD guide and is the head of the department of Krishna Deva Raya Dental College and Hospital. And she has contributed to academics under Rajiv Gandhi University of Health Sciences. She has received the VGST KFIS level 2nd grant from the Government of Karnataka and also a research grant from Rajiv Gandhi University of Health Sciences in 2015. In recognition of her services, she was conferred the Fellowship of the Indian Association of Oral and Maxillofacial Pathologists at the 23rd IOMP conference held in Bengaluru in November 2014. She has authored and co-authored multiple chapters in the Auburn's textbook of oral histology and embryology, contributing from the 12th edition to the 16th edition, which includes chapters on salivary glands, lymph nodes, cementum, and periodontal ligament. She is also recipient of the Best Paper Award at the 28th National Conference of IOMP held at Kovalam, Thiruvananthapuram, for a research titled Expression of PD-1 and PD-L1 in Oral Squamous Cell Carcinoma and Leukoplakia IHC study. Beyond her academic and research achievements, she is a very dedicated clinician and practicing oral pathology for over 25 years. Ladies and gentlemen, it's my proud privilege to have with us today a leader whose career exemplifies scholarship, service, and clinical wisdom. Please give her a loud round of applause. Welcome, Dr. Radhika.
So, good afternoon to all of you. So, first I want to apologize because I am biting into your lunch session. So, I will keep it crisp and short for all of you. And much before I get into my topic, let me tell you that this presentation comes from the Department of Oral Pathology from the Krishna Deva Raya College of Dental Sciences. And today we will speak, I'm not going to, load you with oral cancer data, which is largely histopathological, but I will deal with what is called as diagnostic oral pathology, which is an evolving science and searching new frontiers to pass. So, before I start my talk, I want to actually dedicate this lecture to one of our teachers who was called as the Queen of Oral Pathology and Queen of General Pathology. She is actually Dr. Anita Borges. So she was in the Tata Cancer Institute. So she is half surgeon, half pathologist, half oral pathologist, and a great contributor to tumor pathology actually. So there is, there are very few people in our faculty who will tell that I have not learned anything from Anita Borges madam. So she is a teacher of teachers for all of us. So I hope she stays, and I am sure she'll always be in our hearts, she'll always be in our brains, and she'll always be in our reports also because she has taught us so much. So all of you will realize that oral pathology is going through a renaissance of sorts. It is actually evolving as a vibrant and evolving science of reporting. So what we look at here, we can categorize under 3 brackets to start with to understand what I am talking about. It starts with, what is the requirement of the oral surgeon or what is the requirement of the clinician. Next is how do we refine it to deliver it to them, and it becomes, contributory in the treatment of the patient. And reapproach, some things we have been doing, everyone has been reporting for ages and ages, but do we need to reapproach the whole issue in a new way? So that is what I am going to talk to you about. So all this, whether it is requirement relating to it, adding refinement and reapproaching some topics, is going to give you a much better clarity of what work or what deliverance you want to give. When I talk of a clearer picture, I actually want to tell all the young clinicians who are sitting here that there is something called clinico-pathological correlation. So if you want a clear picture, invariably this is the first step where you start. It doesn't matter whether you're an oral pathologist or an oral med guy or an oral surgeon. I'm sure all of you have visited the ophthalmologist. When the first lens is put, you can actually see the alphabets. There's no doubt about it. But all of us realize with the addition of the lenses, you get complete clarity to read the smallest note or alphabet in the last row. So that is the clarity you will get if you combine clinico-pathological correlation. What you will get to see clinically, the clinical detailing of the patient, then imaging, whether it is an OPG, whether it is a CT scan, whether it is a PET, whether it is a luminescent test, all of that added together, finally a note from the pathologist. Only this actually can effectively complete a story. So this is called as clinico-pathological correlation. So this starts at multiple parameters. We have actually evolved so much in that. For example, in imaging, we have gone from a life of 2 dimension where we used to see only X-rays, we have come to 3 dimensions. So actually, we believe that sometimes it's the oral pathologist who will choose the site of biopsy. Actually, the OMED guy can also tell that, madam, the lingual plate is very thin. You can approach from this area for this ameloblastoma and get a biopsy from there. So enormous contributions actually come from clinical relevance, from imaging, and the surgical detailing. A lot of people have problem to call back the surgeon and ask them about the details. We all know that everyone is busy, but it is very important to get back to the surgeon and get some, surgical note from him. For example, sir, did this lesion bleed a lot? Did it shell out easily on its own? Sir, how large is the lesion? Is it spreading across multiple parameters in the oral cavity? All of this detailing, if the surgeon gives you, actually you walk towards the diagnosis with much more confidence if you receive a surgeon's note. And finally, histopathology. So if you follow this algorithm, I am sure you will generally get a good diagnosis. The error of judgment becomes less and less. And then you can even take a big hand or a contributory hand in prognosis, treatment planning, and suggestion to the clinicians, whether he's a clinician or an oral surgeon. So this leads to a better practice, a better professional working. You will invariably contribute to the health and better treatment of the patient who has actually come to you seeking for help. So what is so different about oral pathology? Sometimes general pathologists tell that, what is so different about you oral pathologist? You are non-clinical subject. You keep on asking clinical details. Why do you do that? So let me tell you, we are less than 1/10 of the whole dimension of the body, where you get to see salivary gland. Do you see the same kind of epithelium all through your mucosa in the oral cavity? No. The gingival epithelium is different from the palatal epithelium. The vestibular location submucosa is very different from the submucosa of the palate. So there is huge amount of variation at different sites in the oral cavity itself. You get different types of tissue like skeletal muscles, salivary gland. So many things are actually seen. And this is an area which is accessible, which you can, access, make an assessment, and then pick up a site of biopsy. So there is a lot of difference of how you practice actually oral pathology. And invariably remember, this is a site where you can get reactive lesions, you can get tumors, you can get diseases which are reflection of systemic pathology. You get a variety, plethora of diseases, all to be diagnosed in a biopsy which is just 1 centimeter or less. So that is why the whole challenge walks into the clinic of an oral pathologist. So that is why oral pathology is very different from general pathology. So how does it differ? So I have a good friend who is a practicing pathologist, and she says that what is so different in oral pathologist when you want to report? So I asked her, what are you sitting with today? So she told, I am sitting with a lump of brain. So immediately I come to know it's an autopsy. So she is not suspecting uterine carcinoma, is she? She is looking at the cause of death in the brain. So half her story is already done, right? But in our case, you get a small biopsy, a half-filled form where you do not even know whether it was healing mucosa, whether he's suspecting PVL, whether it is conventional leukoplakia, and then everyone believes the pathologist will do the magic of diagnosis. So if you have good contribution from all faculties, definitely the oral pathologist can deliver more than what can be expected out of a pathology report. So here I generally see that some of the instances, you will see that 50% of the cases there is spot diagnosis on histopathology. Adenoid cystic carcinoma, squamous cell carcinoma, the moment we see the slide, we know what we are looking at. But there is good amount of 30 to 50% of pathologies which actually need or require mandatory clinical correlation. If I see trabeculae of bone with fibrous tissue and you tell me that, madam, we chucked out a small tumor, I am thinking of a ossifying fibroma. But if you tell me we had to chisel this out, this was merged with the normal bone, then I have to consider a diagnosis of fibrous dysplasia. So invariably you have to realize this clinical pathological correlation is actually going to help me to complete my diagnosis in more than 30% of the cases. So when it is classic, it can be quite easy. But when it is non-classic in representation on the histological level, a good input from the medicine guy, surgeon, everything helps to complete the diagnosis for a patient. So requirement is what I told the first. So in requirement, like I told, the first step is of course CPC integration. Second is, like Nadeem sir told, that you might end up with 2 biopsies which test out to be negative. I would suggest a step of correction. It is good to have, just call the oral pathologist to where the patient is sitting and tell them, see, this is how the lesion looks. Where do you think I need to biopsy it? So if there is an area of ulceration, if there is an area of erythema, if there is a soft lump which is much softer than the other indurated areas, we are going to select those sites where you might actually most of the time probably find invasion. So selecting the site of biopsy is what you can start with assisting in case of oral pathologists when you want to work on a biopsy. Next is appropriate handling and storage of the specimen. It is very unfortunate even today to see that people lump the biopsy in saline, water 24 hours. Please request for 10% formalin, hold it for more than a day, that's okay. But then please hold it in 10% formalin if you are looking to get a good diagnosis of the biopsy that you took, right? So next is you have a plethora of selections that you can do for picking up your biopsy technique also. So just like one of my previous speaker told, if you don't have access, you can use a core needle biopsy. I get true cut biopsies. It is not a textbook term. We get core cut biopsies for salivary gland tumors, some of the lymph nodes, some of the deep-seated malignancies in the retromolar area. You cannot do a conventional incisional biopsy, no problem. Try a punch. You cannot do a punch, you can truly do a true cut or a core cut needle biopsy. So you can actually select what biopsy method will suit your patient. And these days, like I told, you have good assistance that comes from OMED guys. The CT will give you a 3-dimensional picture. Intraosseous lesions, you don't need to take a biopsy from a cystic area. A lot of time we also miss out the diagnosis of ameloblastoma if you give me a very thin cystic lining. So on the imaging, I would actually prefer to go and tell the surgeon, see if a solid area is accessible on the thin or shelled out cortical plate, that is the ideal site for biopsy. So you can get assistance from imaging, from ultrasound to pick up a valuable biopsy which will yield you a good diagnosis. What is the meaning of refinement? So refinement actually means that all the diagnosis, should it end with suggestive? Not really. The oral surgeon is looking at some kind of confirmation from the oral pathologist, which you can give in case you want to complete the report. All of us know when the cancer patient walks into your clinic, it is very, low on my part to just report it squamous cell carcinoma, well differentiated. That is a very incomplete report. As of today, it is valuable. Even if you have an incisional biopsy, do a ANROTH grading. Tell them how many mitosis you are seeing. Are you seeing necrosis? Is there great amount of dysplasia? They can plan their surgeries better, right? So invariably, it is important to grade histologically what you are seeing. If you have a clinical grading system of low risk and high risk, put that grading system also into place. You have to do a clinical and histological staining. And I will even go one step further and tell, if you are aware of the variant, please mention it. Mention it in your report. So if you're looking at a verrucous carcinoma, like Dr. Huda told, you will not look at neck dissection. You will do a much conservative procedure. But if you're talking of a spindle cell variant of squamous cell carcinoma, you're talking of a tumor which is going to metastasize tremendously. So put the name of the variant, give as much data that is possible which is useful for an oral surgeon. So all of this refinement has to walk into your report. Most accepted, whether it is WHO, whether it is Kujan's grading system of low grade or high grade, whatever is accepted clinically among departments is a good practice to use it and put it on your reports. Then reapproach. What is the meaning of reapproach? Like I told, first thing is clarity. So I have, seen pathology reports, including my own reports for a long time. So then you have oral surgeon friends then who read that, what does your report talk of some atypical cells and this looks like this looks like that. What is the meaning of all this? So it's time the oral pathologists actually come out of terms which are not understood by the oral medicine people and the surgeons. So you need to have clarity. It's a bad idea to call something as, atypical ameloblastoma. What is atypical? Please mention it is an ameloblastoma with dysplastic changes. Don't say, atypical dentigerous cyst. Please mention it is a dentigerous cyst showing ameloblastoma-like change. So the treatment modality will actually change for those patients. At least they will be put on a recall. They might put an additional chemical cautery for those patients, and you will take care of the issue which is mentioned. So clarity becomes very important. Synoptic reporting point-wise, which is going to contribute, to add knowledge to how the surgeon picks up a mode or modality for treatment, and of course the detailing. Some details you cannot wipe it off. If you are reporting oral cancer, depth of invasion, differentiation, invasive edge pattern, what is the response from the host side, if there is bone invasion, neurovascular invasion, all this is mandatory. So detailing comes with each set of diseases. In salivary glands, the modes are different. For oral cancer, it is different. So depending on that, you should give the complete detailing. Other than this, you can always add, some value of prognostic relevance. So like sir told, you get a negative margin on frozen section. But if he tells that, madam, this is the third recurrence, I can always suggest, sir, let us do P53. If it is rich in P53, that means it is a genetic predisposition. Maybe we can use targetoid drug therapy in those cases. If you have a high proliferation in some of the tumors, then you can tell the prognosis might be guarded because the chi index is very high in this tumor. So you can add prognostic relevance and few suggestions to the clinician for further support and patient treatment. So I will take you through the daily grind. This is not about only oral cancer. Today I'm going to just talk about, oncopathology as a diagnostic pathologist. So a few thoughts and a few perspectives. I hope you enjoy the presentation. So what is the golden standard for oncopathology? It is a biopsy. Biopsy is the only thing that is going to give you a confirmatory diagnosis. All of you actually know that, what kind of biopsies are there, incisional, punch biopsies. So I'm not going to teach you what is there, already there in the, textbook or in Google. So let's go in a clinical practice what you get to see. But before that, I would like to tell you, please, all the time, when you're doing a biopsy, please select a site and always have in mind, I want this to be a contributory biopsy specimen. So don't do a biopsy which is 3 millimeter. By the time it comes out of formalin, it is 1.5 millimeter. Then I have to do magic. I cannot do histopathological reporting, right? So be fair, get a biopsy specimen in your mind itself. When you are putting the scalpel blade, I want it to be confirmatory. I understand tongue bleeds a lot. I am not asking for 2 centimeter biopsy on a tongue, but at least 7 millimeters to figure out what pathology we are looking at, right? So that is the first thing. Well-handled specimens are well-spoken specimens. I always tell, if you have teased, torn, tissue, it is very difficult, grade dysplasia to take a diagnosis of cancer from specimens which are not handled well or not stored well. And last but the least, I find it very painful when some of the clinician told, I was sure it was periapical granuloma, so I threw it in the bin. Please. Please don't do that. We don't have a right to do that. Anything which is extracted from a living body deserves interpretation. Please send it to the pathology lab. Please don't say the patient can't pay, so I just threw it. No, please don't do that. Send it forward. You might, get a basic report. Hold it for reference. It is for the good of your practice. It is for the good of the patient. So don't discard specimens without getting them analyzed. So invariably, I want to, tell some terms which are generally sometimes confused by the younger practitioners. So I will start with the needle story. So aspirations and FNACs, lot of people feel that it's the same. No, please remember, aspirations are from fluidic cavities. Aspiration can be from a cyst. Aspiration can be from an abscessed area. You cannot aspirate, you cannot use a 1918 bore needle to aspirate a salivary gland tumor. Then what do? In those instances, you do a fine needle aspiration cytology. FNAC is exactly the opposite of simple aspiration. It is done on solid lesions which are soft, which are not accessible maybe, or where you can't do a biopsy. You want to at least have an assessment what pathology it might be. It might be a lump in the palate. It can be a lymph node in the cervical area. All of this you can put to examination using a FNAC. And like I told previously, you can also use core cut needles or true cut needles for pulling out a ribbon or strip of tissue to be analyzed by the oral pathologist. So in this, all the time we feel that only the biopsy specimen is very contributory. That is not very true. You will invariably see if you have, cystic contents, you can get a good assessment from cystic contents also. So when you remove OKC, all of you will realize, if you're clinicians and surgeons, you get a dirty white, off-white secretion which is loads of keratin that comes with the cystic cavity. So in the first shot itself, you can smear the keratin which is lumped, spread it on a slide, instantly stain it, and you will get to see the keratin squams. So certainly you are never going to diagnose it as, an abscess or a dentigerous cyst. You will tell probably this can be a OKC because there's loads of keratin in the cystic lumen. Sometimes you end up with, tissue tags which are quite large in a FNAC. Then it is good idea to centrifuge it, create a cell ball, embed it in paraffin. It will give you much more detailing on the tissue level and give you a better diagnosis. So a lot of modifications can happen with the samples that you receive in your hand while treating the patient. So you will invariably get better clarity much before you write down the final report. So as we learn, so we practice. So sometimes we have very small pathologies like a squamous papilloma, a mucocele. So what is the story? Small lesions, small biopsies, these are treatment biopsies. So these are very simple to do and simple to report also. But what happens when you get large biopsies or excisional biopsies? What are the details to be given by the clinician? You have to tell me. It was interesting to hear when they told, should I use scalpel or should I use laser? So I was tempted to get up and talk. I told, let's hold the horse till my turn comes. So I will invariably tell, to control bleeding, laser is good, but if your tissue is just 1 centimeter, please use a scalpel blade. Why? Because there are a lot of artifacts that seep into the epithelium when you use a laser. Then I cannot tell you that 100% I have given you the correct grading for dysplasia. The cellular and tissue architecture is lost with laser and thermal curating agents, right? So invariably you will have to ask, why do I see this balloon kind of cells? Call back the surgeon. Did you use a scalpel or laser? Laser, okay. Then you have to overlook those changes. You cannot integrate it as a dysplastic change, right? Next is orientation and labeling. It is very important. Figure out, ask the surgeon, get it labeled, which is the anterior border, which is the superior, where is it talking with the maxillary sinus, which was the surface which was close to the bone. Because you will pick multiple samplings from those areas, not only as margin, even to evaluate the pathology that you are going to see, right? And invariably, the details which are given by the oral pathologist, I don't say that all the time I am going to ask and take you. There are a lot of things you can ask me. What all can you ask me for? Madam, please grade it histologically. Please stage it histologically. What is the variant and variation seen? Even if it is squamous cell carcinoma, madam, did you see it in verrucous carcinoma or it was conventional invasive carcinoma? You can ask me about the invasive edge. A lot of specific detailing can be included, which can be whether it was hemorrhagic, whether it was inflammation rich, whether there were a lot of eosinophils, which lot of eosinophils in a tumor bed speak of poorer prognosis. Similarly, you can ask about proliferation index, you can ask about molecular markers if you need to know the tumor better much before you want to treat it. So all these detailing you can get from a oral pathologist. So sometimes you feel, is it about everything about doing biopsies, large biopsies, asking more? No, not all the time. You end up with scenarios where you don't need to do a biopsy at all. It is not mandatory. So in case of hemangiomas and high volume AV malformations, actually you will get the diagnosis by the other visualized aids that you get to see, and only if it is injected with sclerosing solutions or it goes in for an exploratory procedure, you might end up with a biopsy. Similarly, some of the bone pathologies like cementoosseous dysplasia or already diagnosed case of fibrous dysplasia, you don't need to repeat the biopsies. Most of the confirmatory diagnosis can be done using a CT image or a X-ray. So what is meant by planned biopsy? This is where the interesting section starts actually. What is meant by the planned biopsy? So this was a case of a 60-year-old guy who came with a lump on the palate. Everyone knows probably this is a tumor. So just asking him whether he was hypertensive or diabetic, a biopsy bit was taken out. When he came for the report, this was his state. He was in a state of cellulitis and spread of infection. When a detailed history was taken, by then the biopsy report also came, it was a lymphoma, and this guy was a HIV positive guy. So in these instances, it is very important that you get the complete data from the patient. You have to control the disease, cover them, get all the screening done much before you do the biopsy. Similarly, you will see in some of the cases where you have syndromic association. You cannot treat your oral lesion as an independent lesion. So you have to get a summation of what all you get to see in this syndrome. Is it safe for my patient? Is it advisable to do a rapid biopsy in this case? Otherwise, better to plan it. What happens to biopsy in, physiologically altered states? So are all physiologically altered states pathological? Not really. So in these instances, you will see that some of the women who are actually pregnant are in different trimester. You cannot do a biopsy just because you wanted to do it. You will have to seek a clearance from the OBG person. You will have to seek a clearance whether she is having diabetes, hypertension. You will have to seek a clearance whether she is pregnancy diabetic. So many considerations come into the picture. So just like you have physiologically altered states, you will have to think of altered states which are pathological also. So the first is very common. All of us know whether you are hypertensive, diabetic, HIV positive, that is systemic health. Also people who are on long-term medication. So if people are on blood thinner, do you think you can just take up the biopsy because you wanted to do it now? Not really. You will have to plan it. You will have to get the patient off the thinner 2 days before the treatment, the biopsy is done, 2 days post, allow it to heal. So invariably, you will have to evaluate the non-ambulatory state. Do you want to do a biopsy in a sleeping patient? You have to take a lot of care, otherwise it will get aspirated. So in cases of altered physiological state which is pathological also, I don't say you cannot do a biopsy. You might need to do it, but you have to plan it well. In some instances, it's very important to take, cognizance of pediatric biopsies. Why? Because you cannot take up and remove what all you like, because please understand they'll be in growth spurts. You cannot remove teeth which are going to contribute to the permanent set of dentition. You removed off, a segment of mandible which was a growth center for the rest of the child's life. Invariably, you have to plan it well. And what happens to the oral pathologist with pediatric biopsies? Invariably, the cells are very robust, very proliferating, very plump. So the oral pathologist has to pay a lot of attention that these are, some, cases from pediatric biopsy. So cellularity is common. Plump cells are common. You might have a mitotic index which is also slightly high. Immediately, you should not jump to the bandwagon of rhabdomyosarcoma or sarcoma, which is because I'm seeing it like this, I think it is very cellular, it is a malignancy. You have to hold your horses, get more markers done, give it a thought, have a clinical perspective before you take a call on calling anything a malignancy. Similar to pediatric biopsies, in geriatric biopsies also, you need to pay a good attention on age associations, whether it will heal, whether the patient is diabetic, whether the patient is on what kind of medications, and what are the timelines you want to set. You cannot tell in a geriatric patient, the textbook says it has to heal in 7 days. It might take 10 days. So in geriatric biopsies also, you need to pay some attention. All the time you cannot tell that the patient didn't bleed at all. The vascularity in a pediatric mucosa is quite less, so you need not be very apprehensive about that. So what do you get from the surgeon's table? Like I told, the classical anatomical location, the surgeon will tell you that this was on the buccal mucosa. So immediately I know the epithelium looks like this, and what are we looking at as an epithelial tumor or a mesenchymal tumor? Did this tumor shell out easily from the bone? Good. So that tells me mostly this tumor is well encapsulated. It will have a good prognosis also. What were the contents? It was having a serosanguinous fluid, I will think of ameloblastoma. A clear fluid with an impacted tooth, I will think of a dentigerous cyst. So what was the extent of involvement? What was the texture of the tissue that you cut? It was slipping into the, so I will think of a myxoid tissue. If he says it was rubbery and I had to struggle to cut it, I will think of neurogenous origin tissue in cases of those consistencies. So good amount of input actually comes from the surgeon's note or surgeon's table much before I look at the slide. So what do I get? I invariably get specimens. And my story starts from here. So this is the story of the grossing table. So this is how you get the specimens and how you start evaluating. Every specimen that comes just doesn't go under the microscope, just like that. It gets evaluated grossly. So you see a large lump of mucocele and a very well regulated cavity. So you know it's a mucocele. At the most, it might be a very well differentiated cystic MEC. Next is a cystic lesion which is showing you, lot of cholesterol. So then you know that probably you're looking at an infected cyst or maybe a radicular cyst itself. So lot of detailing comes on macroscopy in oral pathology. So multilocular radiolucency, you open, you are looking into a window, you know for sure you are looking at an ameloblastoma. Similar case, as you see in the last image, there is no cortical plate expansion, but on the X-ray it was multilocular. Then my hinges will tilt towards OKC. Why? Because OKC generally doesn't cause great amount of cortical plate expansion, which is generally seen with ameloblastomas and with the dentigerous cyst. So this is how you get to see specimens. This was one of my favorite specimens to learn from, which we got during COVID. So the rest of our lives, we used to, remove hemorrhagic and necrotic areas when you get periapical granulomas and, pathologies of that sort. But in COVID time, I learned you have to hold on to the necrotic areas and, bad looking areas, because that is where you will find the mucormycosis organism sitting. So the whole narration changes. Then you learn which part of the specimen is contributory and what kind of things you are looking at. So these are different specimens which tell you a story. A floating specimen, a lipoma, a tender coconut like glistening area, myxoid areas, stream of connection where you find lumps, so we call it, beads or pearls on a string appearance. So that is seen in one variant of neurofibroma, right? So then comes what you actually get to see on the slide. So I will start with PMDs and tumor pathology, and in this, the first thing I would like to tell is, like Dr. Srinivas told, leukoplakia. Leukoplakia is a 100-year-old lesion. So all of us know about homogeneous speckled, and if you have untoward changes like ulceration, we will biopsy from that area. What I want to tell you more is, for 100 areas, conventional leukoplakia ruled, and no one knew just 3 decades back. The country cousin of leukoplakia stepped into our lives in the form of proliferative verrucous leukoplakia. So this is where the whole story of, potentially malignant lesion broke the bracket. It came into potentially malignant condition. So we call all of them as PMDs now. There are no lesions and there are no conditions. That is because of we seeing a lesion which was called as, PVL, which has a very high propensity for recurrence, and more than 60 to 80% of the lesions will step into squamous cell carcinoma. They are called as progressive lesion. Irrespective of how you treat them, with some span of time, they will step into a stage of invasive squamous cell carcinoma. So invariably, if you have multiple lesions, I don't mean to say a person who uses, tobacco in this vestibule, 2 patches, this is a case of PVL. No, you have set criteria given by Lepidra, you have set criteria given by CARAD. So you will have to evaluate all the parameters. Most of the time a lady, no habit, that doesn't mean men don't get PVL, right? But female, lateral border of the tongue, gingiva, palatal mucosa, multiple sites of association, then you have to start talking of PVL. In this, the histopathological report can, sound the wrong end of diagnosis, because what we see is very low grade of dysplasia. So be very careful. You will be getting the grading as low grade dysplasia only. But what is the smart thing the clinician or I will do is, I will put it as a high risk lesion. Because clinically I know it is a PVL, but at this stage it is showing low grade dysplasia. But beware, it is going to change its face very soon. So you will grade it as low grade dysplasia, but you will risk it as high risk lesion. So these are the considerations which you need to think of when you look at cases of leukoplakia. So just like Dr. Nadeem told, looking at, red and white lesions, because lot of time they'll be together. So if you see a red patch or erythematous patch or erythroplakic patch, you need to figure out whether it is asymptomatic. Most of the time asymptomatic, a little burning are more dangerous lesions because they are already carcinoma in situ or squamous cell carcinoma when they are biopsied. But if they are symptomatic for a long time, you might be looking at speckled leukoplakia or a case of oral lichen planus. So you have to rule out local and systemic causes of inflammation much before you take a call on the diagnosis of such lesions. So do you find only red and white? Not really. Then you see some kind of pigmentation also, which Dr. Srinivas also mentioned. So invariably, if you get pigmented areas without presence of any lesion, in a postpartum lady, you are looking at melasma. But if you have red and white patches, which is cyclically appearing in cases, and you see loads of pigmentation, this is melanin incontinence, which you very frequently see in oral lichen planus. This might be also seen as a secondary change because of smoking habit. So you'll have to confirm the habit much before you interpret it. In some instances, you will get to see pigmented lesions which are very frank. So this doesn't need a lot of thinking. You are actually looking at a case of malignant melanoma. So malignant melanomas can be very deceptive. They can come as a small ulceration on the alveolus. The commonest site for malignant melanoma is the palatal gingiva. So if you see a highly pigmented lesion on the palatal mucosa, doesn't matter if it's your 3rd DD or 5th DD, please keep, if it's friable, growing very fast, keep a diagnosis of malignant melanoma in your bracket. So what are the considerations for oral submucous fibrosis? This is also a very interesting fight which goes on between OMED people and OPATH people. Everyone says, can't you make out this is a case of oral submucous fibrosis? Of course, we can also make out it's a case of oral submucous fibrosis. The next comes, do you want to really do a biopsy in case of OSMF? Yes, it is mandatory. When and where, we will tell you that, right? And then you get surgeon friends who tell that, madam, if you do a biopsy in OSMF, will it heal? And then I ask them, sir, you are going to treat it surgically, where you are going to rip open the cheek, with a 4 centimeter dimension. You believe that that will heal, but the biopsy site of 1 centimeter will not heal. Let's be fair. If it needs to be biopsied, you need to biopsy it. When will you need to biopsy? If you see the same blanched mucosa of a patient which is responding, you don't need to biopsy him repeatedly. But you see a ulceration, you see an eruption of leukoplakic patch, you see a soft patch, generally these are avascular lesions. That's why it looks leathery. So suddenly you see an erythematous patch. That is your clue, that is your site where you need to biopsy. And the next step, or the story in OSMF, is then you need to know, in oral submucous fibrosis, you are not doing the biopsy all the time to just diagnose it as OSMF. You will get to see the epithelial changes, you will get to grade the dysplasia, you will get to see what is the state of angiogenesis, whether your treatment is going to work here, otherwise there are no blood vessels. You are going to, treat a dead stroma which is completely fibrosed. You will know the status of skeletal muscles. You cannot advocate physiotherapy where all the muscle bands have gone in for degeneration. So you will get an assessment of what is the state of the minor salivary gland. Are you going to treat partial xerostomia also along with OSMF? So the OSMF story gets completed with biopsy only because it is going to add so many features into your treatment modality than just, surgical treatment of OSMF. So similarly, in case of PMD, like Sir told, not all the cases of lichen planus which are responding need to be biopsy. But if you see, some cardinal signs where you see lateral border of the tongue, ulceration, not healing, it is the right time to pick up the scalpel blader and biopsy that site, because that might be the area where you might get to see the invasion. So consideration of PMD, especially in cases of lichen planus and oral submucous fibrosis, is very, very different. Why? Because they are progressive, potentially malignant disorders. Most of the leukoplakia, like Dr. Srinivas sir showed you, it can completely revert back to normalcy. But oral submucous fibrosis and OLP, it is very difficult to tell that is 100% cure. And whether it is going at a slow pace or fast, it is a progressive disorder. And if you get addition of multiple PMDs, OSMF with a leukoplakic patch, okay, leukoplakia with a large erythroplakic patch, you need to evaluate maybe more than one site, because maybe you are already looking at a case of squamous cell carcinoma. So I'll just run through a few cases for your benefit in oncopathology. So this was a 21-year-old lady who came with a nodular swelling on the lip. So it was removed as a mucocele. So what comes on the grossing table? There is no cavity, there is no mucus. So you find a completely homogeneous area which you evaluate that probably it felt very soft to cut. So probably a very cellular area. So what do you see on the microscope? You see an intact epithelium which is not altered much, and then you see nodules of tissue which are proliferating. So if you are an oral pathologist, you will know this is a proliferation of spindle cells, right? Invariably you got to see some of them in the form of nodules. So if you would have palpated the lip better, you would have found, bag of worms or pearl on string appearance where you are having multiple blebs, right? So this is how it looks on histopathology. I am talking actually of a diagnosis of neurofibroma. So even if in doubt, you can use a simple marker like S100 and get, the results. It comes positive. So your diagnosis of neurofibroma is done. So my question to you is, did you complete your diagnosis? Do you think we have done complete justification? Not really, because if you are talking of neurofibroma, which on H&E slide itself you looked at was nodular, which was, lumps, then you are looking at the plexiform variant, that is a nodular variant of neurofibroma. Where do you find nodular or plexiform neurofibroma? It is very commonly associated with NF1. It is associated with neurofibromatosis. So in this case also, the moment we saw the slide, we picked up the phone and called the surgeon, told sir when the patient comes for the report, please ask her, does she have any lumps of this kind elsewhere in the body? Does she have pigmented or depigmented area? So you have criteria for NF1. You can ask the surgeon to clear all that. And unfortunately for us, you can see the right side picture. She had an ocular nodule, she had a nodule in the cheek, she had a nodule in the lip, and she was a case of NF1. So here your diagnosis gets completed when you tell that this is plexiform neurofibroma associated with NF1. That is where your diagnosis is completed, because you're not going to treat them for a simple tumor like neurofibroma. What you have to treat here is NF1. There is a changing story for NF1. A lot of us feel that this is the end game. Now the patient story is over for NF, there is no treatment. No. Lot of targeted drug therapy is coming which will allow some amount of treatment, some amount of shrinkage of the tumor mass itself, so that, lot of soft tissue mass or loss of, the tissue which is growing in especially pediatric patient is not lost. So if you give the complete diagnosis, the take-home story from this case is, all the case detail is important. Please mention it. Grossing will give you good clue whether it's a solid lesion or a cystic lesion. Please name the tumor, name the association, put everything in your format of your reporting form. Some instances, if you need to use a molecular target for IHC, please recommend it. Whether the patient agrees or not, put it on your report that this patient is advised systemic examination. Please rule him out of NF1. Please do these markers to get a confirmatory diagnosis of NF1. So all this will fall in line for a good diagnosis. What is this? This was a case which came from palate, a leukoplakia, and we grade it as, like I told you, low-grade dysplasia. But you look at the biopsy form once again, and the clinician had mentioned there is white patches on the palate and gingiva. So my request to all young clinicians, if you see leukoplakia on gingiva, please examine the whole of the mouth. So we called back the clinician and told, please send us pic from the rest of the areas of the mouth. This is how it looked. The whole oral cavity was filled with leukoplakic patches. So we were actually looking at a male who had a mild tobacco habit, but this absolutely is a case of proliferative verrucous leukoplakia. So not because I feel, you use a criteria system which actually it's satisfied. So sometimes just sending a photo of the pathology is not, complete. Once you see the whole of the lesion or how it has spread across in the oral cavity, only a complete picture will give you a true picture of where your diagnosis actually resides or rests. Associations are to be considered for prognosis and treatment. PVL, in no stretch of imagination, you can treat it like conventional leukoplakia. There is a different set of therapy for that. And this is the most interesting case. I am sure the oral pathologists, who are very few here, will be thrilled by this case. So we found a large cystic lesion in the maxilla, right, which was almost compromising on the antral area. So we did a grossing and it was confirmed, looks like a large cystic area with, thickness in the epithelium. So maybe it's a cyst, maybe a cystic tumor. So both of the considerations sat in place. What do you see on the slide? You see some amount of epithelium which looks very similar to a dentigerous cyst with very close affinity for the antral lining. So then you start thinking, what kind of a cyst is it? Non-keratinizing epithelium. Let's have a closer look. You start seeing mucus cells, you start seeing crypts. So then your diagnosis shifts towards GOC. I'm looking at probably a glandular odontogenic cyst. Some more areas to be assessed. Then you get to see there are places where the epithelium is proliferating highly. So we did a chi index, and the chi index in this case was very high. Lot of mitosis, which you generally don't get to see in cases of odontogenic cyst. And one wall of the cyst showed invasion of an island with lot of mucus cells. So this is how it can go cascading. So from a simple cyst, you stepped into a diagnosis of cystic mucoepidermoid carcinoma. So we did a special stain for confirmation of mucus cells by mucicaramine. Like I told, a chi index proliferation which is very high, and MUC1 is a classical marker which you use for evaluation of mucoepidermoid carcinoma. All of this was done and the diagnosis was confirmed. Now, where is the interesting story in this? the GOC and MECs are both aggressive lesions, right? A cystic MEC is low grade, but GOC is an aggressive lesion. So the treatment doesn't really, get varied a lot. But what is the take-home message in this case? All the clinicians should understand very clearly, divide and rule worked well for the British when they were in India. If you divide your specimen and send it to different people, you are bound to get different diagnosis. Don't blame them for that because you divided it. What do you want? You want a second opinion. Let's be fair. Give the whole specimen to one pathologist, get the whole work and a report done, take the whole set, give it to 10 people. We are more than happy. Our diagnosis will get confirmed. So that's a healthy way of taking a second opinion, not by giving and distributing bits to 5 of the oral pathologists, right? So that's a very poor way of practice. So this is the last case I will want to deal with you in a pediatric patient where you found a lump, on the tongue of a 12-year-old. It was little fibrous, but in some of the areas it was soft. It didn't look very invasive on the imaging, so the surgeon actually dissected it out, thinking that it might be a lipoma or a myxoma at the most. So this is what we see. So in some of the tumors, it is not easy for the oral pathologist. So you will see spindle cells, and you will do you will actually analyze it for multiple parameters. Meaning, is there an added component? Is there necrosis? Is there hemorrhage? Do you see a vascular invasion? Do you see bone destruction? All of which you will do. But what is the different story or difficult story for the oral pathologist? Spindle cell compartment, you can have tumors from the fibroblastic compartment. You can have tumors from myofibroblastic compartment. You can have neural tumors. You can have spindle cells in vascular tumors, lipomas, melanomas, and so many other tumors can show you the presence of spindle cells. So in these instances, most of the confirmatory answer comes from the markers. So here you got dense positivity for vimentin. So we are looking at a mesenchymal tumor which came negative, you thought of a fibroma or a fibrosarcoma, whatever you thought of, most of the conventional markers came negative. So then you start thinking of the rarer tumors, and we did a TLE which is very specific for synovial sarcoma. So all the tumor cells took up the stain. So your confirmatory diagnosis didn't come from one marker. Please realize in some instances the patient or the type of cell dictates the use of a panel of markers. You cannot choose and pick. You need to do the whole marker to get a confirmatory diagnosis. So what are the imaging frontiers in oral pathology? Like I told, single markers to find out the origin of the cell, but very important to understand where you want to look for it. If you are looking at proliferation markers, look at the nucleus. So you have to see the marker at the right place to get a correlatory answer. Similarly, like I told, when you are dealing with salivary gland or odontogenic tumors, you can pick tumor markers. That is valid. But when you go towards round cell tumors, lymphomas, metastatic tumors, you have to run the whole panel. It is not choice for the pathologist. Some of the surgical confirmations also come from the oral pathologist. Just outside the OT, you can get frozen sections done. Frozen sections of the margins are not only for positive or negative margins. Sometimes you also get a request, madam, evaluate it for P53. I want to know whether the margin is already altered, because this was a case of OSCC associated with the PMD. So you can write additional markers to rule out whether the epithelium is normal or already it is altered, and this might be a future site for recurrence of squamous cell carcinoma. You also have a lot of prognostic markers which you can use for the evaluation of tumor pathology. So basically what are you doing? You are looking at something that is secreted or held in a cell, right? So based on specific molecules, by collaborating you can figure out what pathway is in action, or you can also collaborate trying to figure out what is this process, whether it is cell cycle, whether it is cell division, whether it is cell apoptosis. All of this, how is it becoming relevant? How is it useful? all of this gets translated into a medicine or a segment of chemotherapy which is called as targetoid drug therapy. So if you have certain molecules positive, doesn't matter whether you want to call it as XXY carcinoma or PPY carcinoma. If you tell the surgeon or the doctor that the cells are sensitive to PD-1 and PD-L1, these drugs will be used for controlling the dimension of the tumor pre-surgically or for the treatment of the tumor mass itself. So this is the new phase of tumor pathology to which a oral pathologist can contribute to. So concluding my talk, I want to tell you that oral pathology is going through a evolving pace. I don't know whether to call it as a slow pace or a fast pace, but I would really like to request everyone support it because it is here to stay. It is going to become contributory. Histopathology and molecular pathology is going to stay with us for a long period of time. Don't be fooled to tell yourself AI is going to replace a pathologist. There is lot of time. There are 2 decades of work going on uterine carcinoma and breast carcinoma, and still they are struggling to find out a program. So if you put a lump on AI, for example, I can give you, this is my favorite example. Give them a piece of lichen planus. Loss of basement membrane, yes. Cells coming down into the connective tissue, yes. Inflammation, yes. There is dysplasia, yes. You are looking at carcinoma in situ. No. Oral pathologist will tell you it's in the active phase, it's an inflammation associated dysplasia. This will heal. Let's call him after a week and see, evaluate the mucosa for healing. So AI is not going to do anything. At the most, on today's stage, it can assist you. It has to work with the pathology department or pathology guys, whether it's general or oral pathology, and there's a long way to go. Till then, it is just support. There is no story of replacement. Integration. All the young guys, more than CPC, my favorite word is CRISP. What is CRISP? Clinical data, related imaging, surgeon's note, and then pathology. Do the whole workup. Then your error of judgment to give a diagnosis becomes minuscule. Customized care is something which is going to come and stay with us for a long time. So oncopathology and oral pathology reporting will actually contribute to that. So they will tell you, madam, this is HPV positive cancer. So the way you will treat HPV positive cancer is very different from conventional OSCC, which is HPV negative. So treatment lines are going to be much more customized with the use of molecular markers. And in oncopathology, it's not about only diagnosis. It will also help you in prognostication, treatment planning, and much more. So there are a lot of things to do, lot of technique sensitive methods, lot of technology on your hand. So do you want to tell me all this is present in my clinic? No, not really. But still today I practice diagnostic pathology very comfortably. How do I do it? Don't forget, you're in Bangalore, you're in Swiggy land, you're in Denso land. Just get the right person to do your RT-PCRs, get the right person to do your molecular markers. When the reports come to you, you need to think, integrate, look at your histopathological presentation. You can draw good, conclusive diagnosis for any pathology if you ask me. But my request is, whether you do it, give it to others, please complete the protocol. Partial protocol is wasteful. It is actually not helping the patient. That is something which we shouldn't do at all. So a big thank you for all of you for your kind, attention in our lunch break time. So thanks to all the youngsters who are sitting here who decided not to vanish. I very humbly thank you. Of course, I want to thank Madam and Dr. Soumya Madam, Department of Oral Pathology, Ramaya Dental College and the Ramaya University for giving me this opportunity to share and relearn this topic with all of you. And of course, my friends and colleagues from my department in Krishnadev Raya and my friends and colleagues from our CARE Oral Pathology Services. So I want to extend my thanks. So most of the time I tell, the dialogues are mine, but the movie is theirs. So these are all guys who contribute largely to my presentations. What you see is, a good contribution from all my colleagues. Thank you so much.
Thank you so much, Dr. Radhika. That was an excellent lecture. This is not the first time I have listened to her lectures. Every presentation of hers has been a treat to the students and all of us in the subject of oral pathology. As Dr. Radhika pointed out, clinico-pathological correlation is very important. So my advice to all the postgraduate students in oral medicine and diagnosis, oral and maxillofacial surgery and oral and maxillofacial pathology is, please work together. When there is a case, I think all the students from all the departments should go there, see the case, and see where the biopsy has to be taken and how it has to be transported in formalin, how much of formalin has to be put, because everything matters. As Dr. Radhika said, some cases in histopathology, we can diagnose it just looking at the slide. But some cases, we need a lot of information right from the radiograph. Radiographs give us a lot of clues in diagnosis, whether it's uni or multilocular, or whether there's an impacted tooth or whether the teeth floating. When you you can see as if the teeth are floating in the radiograph. That all matters to us in the diagnosis. Secondly, oral surgeons, when they do the surgery, what are their findings? Was there bleeding? Was there keratin-like material? Was there a straw-colored fluid? Or anything else they found? That also matters a lot. And when it comes to us, and especially oral surgeons, when they do the marking or when they mark the margins, it's very important for even the oral pathology students to see that markings and see which are the margins that have to be marked, because that also, especially resected specimens, it really helps in diagnosing the cases. So it is very important. There is a clinico-pathological correlation. For us, histopathology is a gold standard, but sometimes we need to use molecular diagnostic methods, especially immunohistochemistry, to diagnose the cases. So it's very important for all three of us to work together and get all the details before we pen down the report. Thank you.
I will just take a minute. This is what happens when one of your good friends sits for moderation. So let me tell you, Dr. Sharda Madam is also my mentor, and much later in my life, she is a mentor and friend to me, because we have walked oral pathology for more than 25 to 30 years, and lot of learning for me comes from Sharda Madam also. So thanks a lot, Madam.
Do we have any questions from the audience? We don't have? Okay. We request Dr. Sharda ma'am to kindly facilitate Dr. Radhika ma'am, the keynote speaker for the day. We have one question from the audience, ma'am.
Well, it was a very good presentation, ma'am. It was
Thank you very much.
real eye-opening for most of the youngsters who are here. And the etiquities, protocols, what to be followed from the point of oral pathology for a better diagnosis and better treatment to the patient. The one question regarding our submucous fibrosis you are mentioning, the maxillofacial surgeon hesitate to go ahead with the biopsy. We being a maxillofacial surgeon, sometimes we agitate because it causes fibrosis. It worsens the condition of the submucous fibrosis. and we are scared where to go ahead with the biopsy. Exactly where to take, because it worsens and causes more fibrosis. First of all, there would be a trismus as well. There are other techniques to take, but my other consideration is that we should also take, as you were mentioning, to rule out some other things also. Like submucous fibrosis might lead to the squamous cell carcinoma also. To rule out all those things also, it is required. And we actually, what we do is we consider a frozen section most of the time. Anyway, we are going to operate it. We'll just operate, release the fibrosis and send the frozen. If it was really involving, this squamous cell carcinoma, that's why we agitate. Otherwise, nothing. Because of the fibrosis is the bigger concern.
I absolutely understand, because I've worked with a lot of my friends who are surgeons. Like, I understand what you're telling. So I actually did my post-graduation from Nagpur, sir. So where we have, 5 to 10 cases of OSMF every day. So one of the protocols we devised, which was less traumatic but easy to do, was to use a 7mm punch biopsy, sir. So we used to do a very small punch biopsy for confirmation of diagnosis. But even then, I agree with you. Lot of cases which are, not symptomatic and have stayed quiescent or, are resilient, we will not advocate biopsy in that. But if you see a ulceration, a red patch, suddenly a soft area develops in a, leather-like background, those are the areas we become suspicious about. Then we ask that it is better to biopsy this. But otherwise also, I feel a punch is good, sir, because it is very difficult to assume what kind of dysplasia will be there in this case. Everything might look white, but he might be in a stage of severe dysplasia. There is no vasculature in these cases, sir. So there will be no erythema. So it can be very deceptive at times. So that is our fear.
I think probably in the future there is some concept called as fluorescence. Some diagnostic measures are there in oral medicine, which will concentrate on the more dysplastic tissues where we can consider. Probably in the future they will guide us.
Staining and imaging techniques will actually help us in this.
Yes, ma'am. Yeah. Thank you, ma'am.
I have just one more question.
Please.
Most of the times we have cyst cases where we have aspiration tissue. But what next? I mean, how many centers will work on the aspiration specimens, and what all can be derived out of an aspiration specimen?
Okay. Sir, do you want the true story?
Yes, ma'am.
Yes, sir. Thank you very much. So I will tell you, most of the cyst cases that we see in our scenario, sir, most of them are infected. So even in my clinic, generally I will be standing with my associate and, I'll have 3 ml, 2 ml of cystic fluid. And I'll tell my colleague, what do you want from this? So he told, madam, they have sent for examination. So I understand that. Sir, invariably, all the infected cystic contents are similar. There is no diagnosis we will reach with that. Truly, the only value I can add is, I can tell you whether this is infected or non-infected, sir. But if you find lot of cholesterol, lot of lymphocytes and all, it tilts towards an inflammatory cyst. It tilts more towards a radicular cyst. But some instances we get good clues, sir, about diagnosis. So most of the time we find serosanguinous fluid which is highly blood tinged, whether it is, light reddish brown or chocolate red brown. This we very frequently find in ameloblastoma, sir. Because of the collapse of stroma, there will be hemorrhage into the cystic fluid. So the moment I see that fluid, I tell generally we have to be careful, this might turn out to be an ameloblastoma. But if you have a gel-like, or keratinous or white, dirty white secretions which are much thicker, we can actually take it on the slide, make a smear and analyze it, sir. So I do not really agree with, textbook analysis where they tell protein content is this much, then it is dentigerous cyst. That doesn't happen in clinical practice. But you get a good idea of whether it is OKC or a ameloblastoma or a dentigerous cyst you are looking at. That is because of the color of the cystic fluid and the further analysis which you will take up.
Anything, any recent advancement, ma'am, where we can take a tissue aspiration and send it for molecular estimation or markers? Any markers can be conclusively derived from...
markers are very difficult from cystic fluid, sir. You have to have tissue.
Tissue.
Yes, sir.
Okay, thank you. And next question, which centers are actively working on aspiration contents?
Sir, I think Soumya madam also will happily work, but we are also practicing oral pathology. It is called as Care Oral Pathology Services. So you can reach out to us also. If you tell what is your requirement, then we can format a protocol where we can analyze all of that.
Within how much time it has to be given?
Sir, same day. Otherwise,
day.
it has to go in a freezer and
Freezer.
reach within 4 to 6 hours.
Okay, thank you.
Thank you, sir.
Thank you very much, ma'am. Indeed, your lecture was crisp, like the acronym you had of crisp, and it was very clear, and you all made us proud oral pathologists today. May we now invite Dr. Nonita S. ma'am to felicitate Dr. Sharda ma'am. Thank you, ma'am. Thank you, ma'am, and thank you, Sharda ma'am, for moderating this session. Before we dive back into the next segment, the e-poster presentations, we invite you to treat yourselves to a scrumptious lunch. We will commence the presentations at 2:30.
ആറ് 10 എച്ചിട്ട് നേരം 10 ചെയ്യുന്നുണ്ട് ഫാസ്റ്റ് ചെയ്ത്
is a molecule in a tiny vesicles where you can see some biological constituent of the parental cell treatment. So while we should use saliva, we have some advantages like it is non-invasive, it is painless, easy for monitoring, can be produced in mass screening, it is cost efficient, can be used at any healthcare level, prescribed medicine can be taken, targeted therapy, and most efficient is like histopathology can be appreciated. So when we move to the procedure, first is the patient preparation, collection of the saliva to 2 ml to 5 ml of saliva, processing by centrifugation. Storage can be done short term and long term. Short term in -20 degrees centigrade and long term in minus 80 degrees centigrade. We have extraction of the biomarker. Extraction includes, for example, iron protein, which can be extracted by techniques like PCR microarray, which results in microovens. The microovens is like the data integration and various tools to perform a selection to find out complex biological process minus 80. So, from complex biomolecules, we get enzymes which are very precise and so,
लगन हाँ देखिए ಒಂದು ವಿಡಿಯೋ ಅಂತ
Coming on to the next is brush cytology using computer assisted. Here a cyto brush is used, a specialized cyto brush is used, and the epithelial cells are taken and put on a cover slip, and an adhesive is used. Then using computer assisted and the nuclear cell taken in the same shape and density of the DNA focus on just on the base either negative or positive or so it helps it is better than conventional technology and computer editing.
Radiation
मैं बोल रहा हूँ, मैं डालेगा कैमरा वीडियो जूस तुमको मर पतमा जूस तुमको मर बंद कर दिया बार कोडिंग
बंद कर दो, HDMI निकाल दो और जंग दे दो, HDMI थोड़ा डाला, वो प्रोसेसर HDMI उधर दे दो, बाद में वो ऊपर डाल दे सेट कर, इधर इधर से डाला, दो में ऐसे डाल, इधर से नहीं डाल, तुम ओके तो जरा कैमरा देखो।
changes.
Life. Life.
I was fine when you held my hand. I was fine when you pulled me down. You said the stars would answer. You said our prayers were written down. I was fine when you pulled me in. We were forced to be human. And then the world came after. And I had never questioned it. And they said it was wrong. We started it all.
check. Check, check, check. Check, check. Hello.
Good evening.
Ask for kind attention. May you have your kind attention.
May we have your good evening, respected
to warmly welcome you all to the valedictory ceremony of the National Oral Cancer Conference 2025. Over the course of this conference, we have witnessed an inspiring exchange of ideas, insightful deliberations, and meaningful academic discussions. Each session
indeed fitting to pause and acknowledge the depth of learning, fresh perspectives, and inspiration that NOCC 2025 has offered to each one of us. At this juncture, it gives me immense pleasure to invite Dr. Dominic Augustine, Scientific Chairperson, NOCC 2025.
Good evening, all. So before I announce the awards, once again, I thank all our participants, the online participants, and the offline participants too, from all across the country who've taken part in this e-poster competition. A big thank you to our judges, online and offline judges. So I'll start with the UG Session Awards. So for UG Session 1, the first place goes to Pooja Valmiki from Maratha Mandal, Dental College, Belgavi. Second place, Sadhya Sambhavi, Albadar Rural Dental College. And third place, Farwa Mohammed and Khatija from Shivamoga. We thank Dr. Vineet Kumar and Dr. Madhavi Naidu for judging this session. UG Session 2, thank you to the judges, Dr. Rajnikant and Dr. Rohit Prasad. First place goes to Dr. Saif Ali. Second place, Ms. Ashruta from Savita Institute of Medical and Technical Sciences, Chennai. And Sanika Dothre and Nitya Shri from Al-Badr Rural Dental College. PG Session 1, the winners are Dr. Buddha Varshita, Vaishnavi Marge, and Renu Sharma, respectively. We thank Ashwini ma'am and Dr. Parimala Sagar for judging this session. PG Session 2, the winners are Dr. M. Parashakti, Dr. Maria Ahmed, Dr. Ayushi Goshal. And we also had 2 faculty sessions. Faculty Session 1, winner Dr. P. Karthika, Dr. Soumya Anandan, and Dr. Pavitra J. Thanks to Dr. Sejal and Dr. Chatura Mohan, who were judges. The last online session, that was Faculty Session 2, the winners, Dr. Anila K. and Dr. Vardendra Manvikar, Dr. Dhaval Pandya, second place, and Dr. N. Chitra from Chennai. Thank you, and congratulations to the winners. So let me move to the offline events. We thank our judges, Dr. Jyoti and Dr. Shilpa Joshi, who've adjudged the UG Session 1. I request the winners to come on to the dais. The first place for UG Session 1 goes to Ananya and Lipakshi from Government Dental College. Please come on to the dais. I request our Dean, Dr. Kavita Prasad ma'am, to hand over the certificates and trophies. The second place goes to Ms. Kritika Diora and Kushi Varshini from Faculty of Dental Sciences. The third place goes to Sneha Arvind and Shreya Radesh from RV Dental College and Hospital. UG Session 2 judged by Dr. Soumya Markala and Dr. Anita J. The winners, first place Malavika Vinod Nair and Joshua from Faculty of Dental Sciences. Please hurry up onto the dais. Second place goes to Kritika and Anuruddh Nair, Faculty of Dental Sciences. Third place goes to Sanjana Chowdhury and Sonika KM, Government Dental College and Hospital, Bengaluru. We move on to UG Session 3 judged by Dr. Bhavana TV and Dr. Gauri. The first place goes to Seniye Jha, Faculty of Dental Sciences. The second place goes to Ashna Opal Adiga, Faculty of Dental Sciences. Third place goes to Chinmay Barua, Keli Society Institute of Dental Sciences. Kindly hurry up. We move on to UG Session 4, judged by Dr. Nonita S. and Dr. Yashwant. First place goes to Suhani Kundu, Faculty of Dental Sciences. Second place goes to Shreya Arun, Faculty of Dental Sciences. And third place goes to Supriya R, RV Dental College. Supriya R, RV Dental College. The last UG session 5, judged by Dr. Vaishali K and Dr. Grishma Chandrasekhar. The first place goes to Malika Mariam, Ambedkar Dental College and Hospital. Second place goes to Smritmika Sundar, Ambedkar Dental College and Hospital. And third place goes to Arya Danu Rao, KLE Dental College, Bangalore. Please give a big round of applause, not only for the winners, but for the judges who've sat for more than half an hour. It was very grueling for them to sit and judge over 16 posters per session. Next, the PG session. PG session 1, judged by Dr. Suma S. and Dr. Pavitra Chandrasekhar. The first place goes to Dr. Akshata and Dr. Asna Azim, Faculty of Dental Sciences. Second place, Dr. Aryan Vadera, Government Dental College, Bangalore. Third place to Dr. Ramanand Basidoni and Dr. Sri Lakshmi, Faculty of Dental Sciences. Kindly come forward and receive your awards. Very befitting and appropriate for the oral surgery dean and HOD to felicitate their students. PG session 2, judged by Dr. Shweta KM and Dr. Ranganath. First place, Dr. Amoga, Faculty of Dental Sciences. Second place to Dr. Gopika Menon, Government Dental College, Bangalore. And third place to Dr. Saida Nafia Fatima and Dr. Roshni Malu, who've come all the way from Bomanali, from Oxford Dental College. Our faculty were not far behind in having the same enthusiasm as our UGs and our PGs. The winners of the faculty session And second place to Dr. Shweta Venkatramana, Faculty of Dental Sciences. I request Thank you, madam. Please take your seat. Please don't be disappointed, dear students, participants, if you haven't won. There'll be many more conferences coming up in Ramaya where definitely you can present once more, okay? So please don't be disappointed, okay? So let me conclude this valedictory session by thanking our student organizers. That is the people whom you see here, Dr. Anusha, Dr. Nidhi, Dr. Rishita, Dr. Anvita. You should move on to the next when you can't remember. Okay. Nitya Ganeshan, how can I not remember her name? Come on. And Dr. Danya, Dr. Sanjana, and Dr. Samadrita. Thank you so much. They've taken care of the inauguration and the valedictory. Then our registration team, Dr. Yaki, Dr. Harshita, Dr. Sejal, Dr. Muaz, Dr. Sridevi, and Dr. Sana Mariam. Thank you so much. And of course, our boys, Dr. Sai Sanket, Shubham, Apurv, Animesh, and Nitish Raj. And of course, Subhan Seth is not in the picture. And Ritik too. Thank you so much. Thank you all. Thank you once again.
As we approach the conclusion of this prestigious conference, I would like to express our heartfelt gratitude to all those whose dedication and unwavering support ensured the smooth and dignified conduct of this event. The leadership of our university, including the Honorable Chairman, the Honorable Vice Chancellor, Registrar, Provost, and the senior administrative authorities for their constant encouragement and support. I would like to extend my heartfelt gratitude to our Dean, Dr. Kavita Prasad ma'am, who has supported us throughout this endeavor, and everything was very smooth with her because of her. Our session moderators for steering the discussion with professionalism, balance, and academic excellence. I would like to thank our distinguished speakers for their sharing their expertise and enriching each session with valuable insight. Our sincere gratitude to Mr. Gopal Krishna sir, Administrative Officer, for his continuous guidance and support throughout the planning of the event.
The faculty, teaching and non-teaching staff of our institution whose coordinated efforts were instrumental in organizing this event. The audio-visual and technical teams, both in-house and external. A special note of thanks to Mr. Anthony and team, Mr. Nagesh for the facilities, Mr. Sri Shetty and team, for enabling seamless presentations, communication, and hybrid participation. All of our delegates, both in person and online, for your enthusiastic participation and valuable academic contributions. And finally, our volunteers, whose dedication, discipline, and behind-the-scenes effort form the backbone of NOCC 2025.
At this moment, I would like to invite our Dean, Dr. Kavita Prasad ma'am, to give the concluding remarks. Please, ma'am.
Very good afternoon, dear students and faculty. I hope you enjoyed today's sessions, all the lectures and your poster sessions, and very happy with your prizes. Yeah. So we were also very happy to host you, and I congratulate the Department of Oral Pathology and Microbiology at the Faculty of Dental Sciences, Dr. Soumya SV, the organizing secretary, and Dr. Dominic, the scientific chairperson of this event, Dr. Surendra, the scientific convener, events coordinator, and Dr. Hajira, the scientific convener, the entire department of oral and maxillofacial pathology at FDS. I think they have put in a lot of effort from the past 3 weeks to bring this conference together, and we are very thankful to each one of you for your enthusiastic participation in this event, both online and offline, and I see that a lot of students participated in poster competitions as well. And I think the lectures were very engaging and informative. And I think it was a lot of information for you to take home and also to bring it into your clinical practice. So as dental professionals, if you have taken one small message home that when you do a examination of a patient next, to take, give importance to the case history, give importance to the habits and their lifestyle, and to do a good general and oral examination, and also to immediately inform them if you see some untoward changes in the oral mucosal surface, and give them the correct advice and take preventive measures, for them to take preventive measures. I think we have achieved our goal. So I think you will all take this forward and make it into a habit, an everyday habit in your clinical practice to do a good examination, because that goes a long way in diagnosis and a long way in preventing oral cancer, because prevention is the best cure, like all of you know, because once a patient has oral cancer, be it in the early stages or in the late stages, then it becomes very difficult for us to predict the prognosis, like you have seen. With the best of the treatments, with the comprehensive treatment, still the 5-year survival rates are still low. So that is why the prevention is where we should focus on. The early diagnosis is another aspect when you pick up the pre-malignant lesions or conditions, so that we prevent it from transforming to oral cancer. So thank you all for being a part of this conference. We have enjoyed hosting you all, and we also, like Dr. Dominic said, we would like to host many more such conferences and encourage students to participate, because you are our future. Thank you one and all. Jai Karnataka. Jai Hind. Thank you.
Thank you, ma'am. We kindly request everyone to rise for the national anthem. Kindly be seated.
Thank you. Thank you all once again for being part of this enriching academic journey. We wish to conduct many more such programs and see you all very soon. You may now kindly proceed for high tea and refreshments, and we request you to collect your certificates from the registration desk. Once again, thank you for your presence and support in making NOCC 2025 a resounding success. Thank you and have a pleasant evening.